Welcome everyone to the roundtable of dental aesthetics. This roundtable will be chaired by the respectable Dr. Theocharides. He is a specialist in prosthodontist, an implantologist, a clinical lecturer at Queen Mary's University, a professor at UC, and a clinical supervisor in our dental clinic. I will now give the floor to Dr. Theocharides.
Thank you, Julia. Good morning, everyone, and thank you for coming. So today we will talk about dental aesthetics, and more specifically about navigating through dental aesthetics. This means how we need to consider all of the aspects in order to have a beautiful smile, basically. So we've separated all of the aspects, and then we're trying to go through the workflow of how things happen. So we're going to start with Fotis Charidos, who will talk about the pink aesthetics, which is basically the soft tissue aesthetics and how they play a key role in getting this beautiful outcome. Then we're going to move into Maria Georgiou, which will talk about the white aesthetics, which is about the hard tissue and what we need to be careful, what characteristics we need to have. Then we're going to move into Lena Dimitriadou, which we're going to talk about the facial aesthetics and how the faces comes in harmony with the smile. And then, so once we establish all of the objectives, what we need to be thinking about to have that beautiful smile, then we're going to look at the workflow. So we're going to look at Georgios Alnazrouis, who will talk about the digital workflow together with Odysseas Lagios. So they will talk initially, Georgios, about how to get that dental photograph, how to transmit this information to your lab and to your patient, to get them on board, to get them to understand what you want to achieve, and then how you have to get the excellent shade, because you cannot get a tooth to be perfect unless your shade is exactly what you want it to be or matching the adjacent teeth. How you would then create these mock-ups, which will be, again, for education, as well as to guide you how to prepare the teeth. And finally, once we establish all of this work, then we're going to move into the actual, scanning, milling, and then actually placing in the patient. So it's all this sequence that needs to come together in modern dentistry in order to achieve what we call a beautiful smile. So I would like to welcome on stage Mr. Fotis to start this. Thank you very much.
Hello, everyone. So, we will start with the soft tissue aesthetic component. For the soft tissue component of this presentation, we are going to discuss the 5 fundamental objective criteria, and also we're going to present 3 cases where the criteria were met after intervention. The fundamental objective criteria for a healthy and natural soft tissue appearance include gingival health, interdental closure, tooth axis, zenith of the gingival seam, and balance of the gingival levels. Let's start with gingival health. Gingival health is the broadest term out of the 5, and it can be maintained by optimal oral hygiene, periodontal therapy if necessary, use of atraumatic clinical procedures, not violating the biologic width, making precise margins, precisely adapted provisional restorations, etc. Gingival health refers to the structure and the appearance of all gingival components. And it is important to identify the relationship between the components and how we can accurately maintain or replicate them. The three components are the free gingiva, the attached gingiva, and the alveolar mucosa. Can I have the pointer, please? Thank you. It's better if I show you guys at the same time. Okay. So we have the free gingiva, the attached gingiva, and the alveolar mucosa. And we're also going to see the two different borders here, the mucogingival border that separates the attached gingiva from the alveolar mucosa, and also, well, the free gingival margin that separates the tooth from the free gingiva, and the gingival groove, which is here, that separates the attached gingiva from the free gingiva. We also have a difference in color, as you can see. The free gingiva has a coral pink color, as well as the attached gingiva, whereas the alveolar mucosa has a dark red color. We also have a difference in the surface and the texture. We have a dull surface for the free gingiva and a firm texture with an orange peel appearance on some adults for the attached gingiva, whereas the alveolar mucosa is loose and mobile and soft. The next component is basically the gingival biotypes or phenotypes. We have the thin phenotype and the thick phenotype. The thin phenotype is more aesthetically challenging since it is more translucent. And you can see here the periodontal probe test. On the left, you can see that the probe is visible through the gingiva, which indicates the thin gingival biotype. And here it's not visible, which indicates the thick gingival biotype. And as you can probably tell, as you can see the probe, you can also see other reconstructions that are metallic. So we need to be careful in that aspect. The next thing we're going to talk about is interdental closure. Interdental closure is defined as the absence of gaps between the teeth. And in juvenile healthy gingiva, interdental spaces are closed by the scalloping of the tissues forming the papilla. When you neglect oral hygiene in combination with periodontitis, diastemata, or narrow root bases, you can alter the gingival architecture and create these black triangles or bigger diastemata, which we do not consider aesthetic. Moving on, the third criterion is tooth axis. So we have a few lines here. We have the white line, which is it represents the axis of the central incisor, and the two black lines represent the axis of the lateral and canine. And we have two observations. The first observation is that all axes incline to the distally. And the second observation is that the axes incline more to the distally the more distal the tooth is. But how is it important for the appearance of the soft tissues? Where it is important because, as you can see, that's point 3. The tooth position and morphology and the gingival contour are interdependent. So we need to make it proper so that the gingiva also appear correct. Okay. The fourth criterion is the zenith of the gingival seam. What is the zenith of the gingival seam? It is the most apical point of the gingival outline, as you can see here, indicated by the T's, or the cross between the T's. These are the points. It usually is distal to the axis, but that's not necessarily the case all the time. For example, in the maxilla, it can be centered on lateral incisors and canines, and in the mandible, it can be centered on all anterior teeth. It is important to know that since we're going to use it for direct and indirect restorations. The fifth criterion, and the last one that we're going to talk about, is the balance of the gingival levels. the balance of the gingival levels is determined by the zenith of the lateral incisor and how it compares to the line between the zenith of the central and canine. So if it is lower, it is, or more coronal, it is class 1, and if it were here, it would be class 2 gingival height. So now that we are familiar with the criteria, we're going to examine 3 cases and 3 different treatment approaches. So the first case, we called it black triangles because, of course, we have black triangles. So it is also known as sequel of periodontal disease. It can oftentimes be closed via restorative means alone, and you can see here the before picture. You can see on the back they had some old composite restorations. The first thing they did is they removed the composite restorations and they replaced them to facilitate a healthy baseline. And then the facial aspect receives veneers, porcelain veneers, to enclose the black triangles and achieve a healthier looking aesthetic and a more aesthetic result of the gingiva. And this is a case by Dr. Theocharidis. On the far left, we can see the before picture. It is a case of lateral incisor regenesis. We can see the before picture on the left. Next to it is the picture showing the angulation of the implants placed. On the far right, we can see provisional restoration. So both of these pictures are with provisional restorations. And the aim is to contour the gingiva in such a way so that when we remove the provisional restorations, we get this emergence profile for the final restoration to sit in, and then this is the final result that was achieved. Okay. As you can see, the final result displayed excellent soft tissue aesthetics. Note the realistic interdental closure, axis, zenith, which is towards the distal, and class 1 gingival height. So for case 3, let's look at all the fundamental objective criteria. As you can see, the asymmetry is due to criteria 4 and 5 mainly, the zenith of the gingiva and the balance of the gingival levels. The zenith of 11 and 13 are lower than the zenith of 21 and 23, and the zenith of 12 is lower than the zenith of 22. The other thing is the balance of the gingival levels. It is also symmetric because of the zenith of tooth 12 is lower than the zenith of 22 compared to the line that connects the other two zenith. So not only is this lower compared to this is also lower compared to the line that connects the other two. And here, the patient went through gingivectomy, and you can see the results are already looking better. And after healing of the tissues, the case is finalized with the addition of CAD/CAM fabricated porcelain veneers in order to increase tooth height and improve aesthetics, another satisfying clinical outcome. And you can also notice the improvement regarding the zenith of the gingiva and the balance levels. A big thank you to Dr. Theocharidis for providing his cases. And now I'm going to introduce to you my colleague Maria, who is going to talk about hard tissue aesthetics.
Hello. Together we're going to discuss about hard tissue aesthetics, also referred as white aesthetics. And we're going to go through the relative tooth dimensions, the basic features of tooth form, tooth characterization, surface texture, and color. So, starting with relative tooth dimension, according to studies, the tooth size is not correlated to the subject's stature, meaning their height, and it's also revealed that anterior tooth width is greater in males than it is in females. And the most stable reference for the tooth dimension proved to be the width to height ratio, because it shows minimal variations between different teeth and between the genders. Now, here you can appreciate on the top right picture how, although all of these teeth have the same width, tooth A is shorter, so it appears to be wider, although that's not true. And brightness also affects the dimension, not like the perception of the dimension, since you can appreciate here how the tooth on the right is brighter and appears to be larger than the tooth on the left, although they have the same dimensions. So, going to the basic features of tooth form, starting with maxillary central incisors, the mesial outline is parallel or slightly convex for maxillary incisors, while the distal outline and lobe are more convex with a rounded distal incisal edge, while the incisal edge itself can either be rounded or irregular. The realistic incisor shape is also related to the anatomy of the interproximal ridges that represent strategic light reflecting areas, as you can see here. In this top view of central incisor facial surfaces, you can see how the mesial transition line angle indicated by the single arrows over here is more prominent than the softer distal lobe and transmission line indicated by the triple arrows. The size of maxillary incisors vary, and they can be, there's three main types of tooth forms for central incisors, and it's square, ovoid, and triangular. Square has a straight outline with marked and parallel transition lines, while the ovoid is rounded with smooth transition line angles showing incisal and cervical convergence over here. Triangular is straight outline with marked transition line angles and lobes showing cervical convergence, as you can see. Now, the incisor facial labial surface can be divided in three planes. We have the incisal, the middle, and the cervical one. And note how the prominence of the mesial line angle over here at the cervical third is indicated by the start, and in opposite, note the flat or even slightly concave aspect of the distal gingival surface indicated by the wide arrow over there. In the top right picture here, you can also see how all of the lobes are converging towards the cervical part of the tooth, therefore creating V-shaped concavities, with the distal one being wider and more apically extended than the mesial one. Maxillary lateral incisors are a very close resemblance to central incisors, but they are smaller in size. They have a more rounded mesioincisal angle, and the labioproximal transition line angles display more apical convergence. And we have, from all of the teeth, the greatest variation on lateral incisors, and it's not uncommon for patients and individuals to show peg-shaped lateral incisors. Now, the last anterior maxillary tooth is the maxillary canines, who are thicker labiolingually compared to incisors. The mesial outline can be slightly convex, while the distal outline is very convex, more incisally, and more flat towards the gingiva area. The prominent central lobe that defines a strong central ridge extends from the tip of the canine mesiogingivally, like it has a mesial inclination, and as you can see in this picture. Now, talking about tooth characterization, so it implies, it implies a complex dynamic light interaction, the phenomenon of reflection, transmission of light, as well as the intense effects and specific effects of form. And I would like to talk about opalescence, which is an optical property of enamel and refers to the ability to transmit a certain range of natural light wavelengths, red and orange tones, and reflect others, blue and lavender tones. Now, enamel normally displays a bluish, translucent, I don't know if you can see it here, effect under direct lighting, and an orange opalescent tone under indirect lighting. So practically, what we use this for is that we want the tooth to be more bluish reflective towards the incisal edge, where it's normally translucent, while we want it to reflect more orange tones in this area. And that's why we can use different shades and types of composite during restorations. Now, surface texture. The determining elements of texture are essentially oriented horizontally and vertically over the labial tooth surface. The horizontal component is direct result of the lines of growth, leaving parallel stripes on the enamel surface called perikymata. Those are expected to wear away after a lot of years. And we also have the vertical component, which is the segmentation of tooth in lobes that we described before. So we have the distal, the mesial, and the mid lobe. And during creating and texturing restorations, we must follow a specific sequence, always starting from the vertical elements, leading to the horizontal ones. Now, for the last criterion, which is color, first we're going to talk about value, which is the only color dimension that can exist by itself with no hue and no chroma. Value basically is the relative blackness or whiteness that we can easily appreciate by turning a picture in black and white. And as previously mentioned, brightness can also affect the size, like the perception of size of a tooth. And it is correlated to surface texture, and it should be prioritized during shade selection. It is quite common to observe a wide range of brightness within the same tooth. Generally, the incisal edge is the darkest one. The lightest one is the middle part, and the cervical part is nor the lightest nor the darkest. And this is expected because we have the highest transparency and light absorption on the incisal edge. Now, moving on to hue. Hue is determined by the wavelength, and it's named after the color family, like red, yellow, green, and blue. But it doesn't have that much of importance during shade picking because we have very low concentration of hues in the teeth. But the perception of hue is influenced by the environmental factors, meaning, for example, here you can see how this tooth, when it's the only one being tinted green, it appears to be a darker shade of green than when all of the teeth are tinted green. Same here, when you have one inflamed gingiva, the tooth appears to be whiter, although these teeth have the same shades. Now, chroma defines the concentration of the hue, like how strong is the hue, how intense. And it must be emphasized that from a restorative material perspective, value and chroma are inversely related. An increase in chroma logically induces a decrease in brightness, like the more intense the color of the tooth is, the less bright it is. This accounts for the loss of value in the cervical third because it is influenced by the root dentin, which has a darker color than the rest of the tooth. Now, the last thing I want to talk about is the retinal fatigue and chromatic adaptation. So, when staring at teeth for shade determination, the retinal of the eye will fatigue rapidly in about 5 seconds. This will decrease the ability of the dentist to choose the proper hue. So, shade evaluation should therefore not exceed 5 seconds and should be followed by staring at a complementary color to restore acuity for the initial hue, meaning since the teeth are yellowish, you should look at something blue. A very good example that proves retinal fatigue is Troxler's fading optical illusion, as you can see on this slide. And if you pay attention at the points for 10 to 15 seconds, you will see that the colored spots are going to start disappearing. Or here, you're going to see a green circle moving around, while in reality, there is no green circle. So thank you very much, and we're going to continue with Lena presenting the facial aesthetics.
Hello everyone, I am Lena and today I'm going to talk about facial aesthetics. This is the table of contents. 1 minute. And sorry for that. Okay. And let's start. Facial aesthetics in dentistry is a broad term which refers to a natural smile and appearance. Position of the eyes, nose, chin, and lips contributes to the identification of the reference points and lines which provide a harmony face. Here is the interpupillary line, and is a straight line which passes through the center of the eyes. Is the reference plane for the occlusal plane of the maxillary teeth, which should be parallel to the interpupillary line. Commissural line is this one here, and it is the place of the mouth where the lateral aspects of the vermilion of the upper and lower lips join. The commissural line is important in facial appearance, particularly during some functions, including smiling, of course. Here is the midline, which is a hypothetical vertical line through glabella, tip of the nose, philtrum, and tip of the chin. So, central incisors should follow the midline and actually of the frenum attachment. So, midline of the face it's centered according to the frenal attachment. Now, the more centered and perpendicular the interpupillary and the midline are, the greater the sense of overall harmony of the face. The commissural and interpupillary lines should both be parallel to the horizontal plane of reference. It is important to mention that the intersection of the midline with the horizontal planes shows the presence or absence of symmetry. Dental symmetry at the midline level creates a pleasing smile even if there are abnormalities in the lateral section. The lower central incisor is the smallest and most symmetrical tooth, and the 4 front teeth from central incisor to premolar are the most significant part of the smile. And the front 2 upper central incisors should be symmetrical in size, length, and shape. Now, facial proportions. well-proportioned face consists of 3 portions of equal size. The upper third, as you can see, is the area between hairline and ophreac line. The middle third runs from the ophreac line to the interalar line, and the lower third extends from the interalar line to the tip of the chin. These facial areas vary in size for each individual. Now, the lower third is the most important area because of the presence of the lips and the teeth. Ideally, the lower third consists of the top lip and the lower 2/3 by the bottom lip and the chin. The distance from the bottom of the nose to the lower edge of the upper lip should be half the length between the lower lip and the bottom of the chin. And when we have a patient with a lower facial height and we are dealing with aesthetics, we have to correct that. So you have to make the lower third to match with the other thirds. So patient with loss of teeth or patient who has significant wear of teeth, the lower facial height may not be in symmetry with the other ones, and with aesthetic dentistry, we can correct that. Now, glabella, subnasal, and tip of the chin joined together and create an angle of 170 degrees, which represents the normal profile, as indicated in the picture. A reduced size of the angle, which is formed by joining the 3 reference points, creates a marked posterior divergence. Convexity of the profile is related to a retroposition of soft tissue progonion. The angle, which is formed by joining the 3 reference points, is greater than 180 degrees and creates an anterior divergence. Concavity of the profile is related to anteroposition of pogonion. Now, something interesting that I found is that patient profiles are associated with psychological characteristics. For example, a convex profile is associated with a dominant and ambitious person. On the other hand, concave profile associated with a submissive and apathetic behavior. Now, E line is the ideal line which connects the tip of the nose to the tip of the chin. It's very useful in determining the profile type, and in a normal profile, the upper lip is 4 millimeters posterior to the E line, and the lower lip is 2 millimeters posterior to the E line. As you can see, based on the photo on the left, it may not be aesthetic, so we try to fix it by pushing the lips to the right position. In the ideal phase, the upper and lower lips sit just behind the E line, with the lower lip being fuller, being closer. Now, nasolabial angle, we call the intersection of 2 lines at the level of subnasal. One tangent to the base of the nose, the other one tangent to the outer edge of the upper lip. And nasolabial angle of a normal profile in men is around 90 to 95 degrees, and for women around 100 to 105 degrees. Now, it's very important that the upper and lower lips joined at the labial commissure. Don't forget that your lips are surrounded by circular muscles known as orbicularis, and it is these muscles together with your lips which model the position of your teeth. Height of the upper lip is half the height of the lower lip. And gummy smile, when smiling broadly or forcing a smile, the patient should reveal all of their superior central incisors, including some 2 millimeters of gum. And the truth is that most people show at least 8 upper teeth when they are smiling, and at least 6 lower teeth when they are talking. Lower lip line. The lower lip line is responsible for the control of crown form, length, and incisal edge configuration during a relaxed smile. And patients tend to have a forced smile in front of a camera, so taking photographs of such position can be a challenge. Eyes play an important role to have natural smile, and slight narrowing of the eyes happens when the smile causes cheek lifting, something that creates tiny wrinkles near the corner of the eye. Lateral incisors remain at a distance of 0.5 to 0.15 millimeters from the lip, central incisors and canines, close relationship with the lip line. Patients with higher upper lip will appear increased amounts of gingival tissues, something that involves more restorative efforts to achieve properly dental-gingival relationship. And patients with lower upper lip line are more susceptible to poor oral hygiene and huge dental-gingival insufficiencies because dentinogingival defect will not be visible on those patients. And about the smile alignment, the occlusal line follows the commissural line, and there are always variations between both sides of the human face, and it is contrary to nature to believe that absolute symmetry is required. As a result of those asymmetries, facial
Hello. So guys, my section will be dealing with dental photography, shade selection, and creating digital mock-ups, which are all connected and help bring the most aesthetic outcome. Here's a brief table of contents. Why is photography important? Well, the two main reasons in the aesthetic dentistry include enhancing communication between dental clinic and the lab, and between the dentist and the patient. As for the dental photography workflow, we start with the preoperative photographs, shade selection or shade documentation, intraoral and extraoral photographs, and postoperative photographs. Now, when it comes to cameras, we have a recommended camera configuration. The first decision that will significantly influence the cost and quality level of the equipment is the choice of the sensor size. The camera sensor can be 24 by 16 millimeters, which is called DX, or full 36 by 24 millimeters, called FX. Meaning DX have smaller sensors than FX. FX sensors tend to provide a higher image quality. On the other hand, DX cameras are lighter and much more affordable than FX ones. For a more, let's say, economic camera configuration, we can pair DX camera with a ring light and a 60 to 85 zoom lens. And taking it a step further, we can pair the better quality FX camera with twin light and 105 millimeter prime lens. Now, to talk briefly about the difference between flash systems, we have the twin flash over there, and we have the ring light. The twin light is a 3D light that generates shadows optimally revealing texture, shape, contour. It is best used for anterior, intraoral views, smile views, facial views, and image of casts. While on the other hand, the ring light generates a directional and shadowless light that hides no part of the subject. It is best used for surgery, posterior intraoral mirror photography, and pathology photography. Here are some recommended camera settings, whether it's for portrait or intraoral. You can feel free to take a picture. Now, as for the shade selection, shade selections occurs as following. We have selected tabs of commercial shade guides that are held edge to edge with teeth over there, with the reference teeth. For each patient, the dentist should try to understand and document the color, in quotation marks, tooth-light interactions specifically, rather than just the shade. We're trying to see how the light interacts with the different colors on the tooth and try from there and select the shade from the guide. Elaborating a shade mapping sheet, over there you can see how the different colors go differently throughout the tooth. Elaborating a shade mapping sheet with a reference to custom shade tabs for specific porcelain masses. Digital photographs with cross-polarization will facilitate this step. Advanced shade selection. In order to measure tooth color from an image for a better analysis of intrinsic details and characteristics, cross-polarization filters, as you can see here in the camera, is essential to eliminate obstruction from specular reflections of the tooth's shiny surface. For the particular purpose of colorimetric measurement, a neutral gray reference card needs to be placed just below the incisal edge during image acquisition. This is the reference card, the gray reference card. And here we can see it being used under the incisal edge to better have a calibrated color for the ELAB later on. In order, excuse me, yes. Once the colors are calibrated using Adobe Lightroom or any color editing software and associated software such as ELAB. By using ELAB Prime software over here, artificial intelligence algorithms not only automatically analyze the shade distribution, but also provide a patient-specific shade mixing recipe for the dental ceramist and for the most commonly available ceramic systems. This simple process provides the ability not only to quantify the difference between the target tooth color and the restoration objectively, but also to analyze qualitatively via comparison of intrinsic effects and incisal characteristics. The ELAB system thus provides an inexpensive and reliable tooth for objective shade communication between dental office, the dental laboratory, for increased predictability and accuracy. Now, for digital mockups. After shade documentation, a digital try-in or a digital mockup takes place to better assess the aesthetic results. We utilize a 3D computer-aided software such as SmileCloud, which allows us to simulate and visualize dental treatments digitally. This also helps improve patient communication and understanding. Digital mockups in dentistry are computer-generated. Digital mockups in dentistry are computer-generated models of patients' desired teeth and oral structures. This is the overlapping over natural teeth, as you can see here. It is used for treatment planning, visualization, and communication. Their popularity has grown with advancements in digital dentistry and CAD/CAM systems. Advantages for dentists include improved case presentation, enhanced diagnostic capabilities, increased efficiency, reduced chair time, better collaboration with dental labs. The patients also get a greater understanding of treatment options, visualization of potential outcomes, informed decision-making, and higher satisfaction rates. As for mock-ups, mock-ups are true and tangible preview of the final treatment. This allows the patient to fully experience the new smile as it is placed directly in the mouth. Mock-ups give an opportunity for the patient and dentist to observe and make adjustments at the stage in order to avoid corrections later on at the stage of permanent crown or veneer placement. The digital mock-up is integrated with an intraoral scan, which will be mentioned later by my colleague Odysseas. This integrated scan is then 3D printed, and a silicone putty is used to create a key with a desired teeth shape from the 3D printed digital mock-up. This is the 3D printed model from the digital mock-up, and this is the silicone putty used for the silicone key. Before the silicone key is filled with bisacryl material and transferred to the mouth, the cuts on the silicone are made for ease of excess material removal, which allows a perfect adaptation of the material. After the bisacryl is set, the silicone key is removed from the mouth, thus revealing their future smile. Here we can see the placement of the silicone key with bisacryl in the mouth on the left. And on the right, the video on the right is the before and after of mock-ups. Now, leading to preparations, we have something called the mock-up guided preparation. We can choose to proceed with teeth preparation on top of a mock-up, or we can remove the mock-up and use the silicone key that was used as indices while preparing. This allows for maximum conservative preparation for veneers and crowns. Thank you so much.
Hello guys. Last time I was on a stage, I was at my school, and people were voting me if they want me to be a DJ. It's the same amount of nervousness today. Okay, so I'm gonna talk to you about digital workflow. I'm not gonna bombard you with any theory, so if anyone wants, you can just ask a question. We can do something like a discussion, whatever you don't understand. As we have seen from Yorgos' presentation, with the use of digital dentistry, we're able to preview the final result of the treatment. So that gives us predictability. This is very, very important because we can see like errors that might happen, and we can foresee them and avoid them if possible. I believe that an aesthetic outcome is also a functional outcome. And when I say this, I'm saying this because if you imagine that we have an aesthetic, a red-pink, well-contoured gingiva, this gingiva is also healthy. It's aesthetic as well. An aesthetic restoration with tight proximal contacts and without diastemas is also functional. No food can get in. So to achieve this, some protocols and rules should be followed, and in this section I will analyze the digital workflow and explain some essential techniques. Okay, so as you know already, we start from crown preparations. I'm not going to get into that. Dr. Theocharidis has done an amazing job in teaching us all crown preparations. Let's get with the intraoral scanning. So what is an intraoral scanner? It is a device that gets digital impressions of the oral cavity. A light source is projected onto the hard and soft tissues of the mouth, and the 3D model is processed by the scanning software and is visible on the screen. So, okay. This has some advantages, and by using the intraoral scanner, we have a lot of advantages in this section. First of all, they are touch-free, providing a comfortable patient experience as no materials can drip, except if you want to have something like a pharynx impression. So, they also provide a high accuracy of the 3D models. That means little to no errors. It provides an accurate fit of restorations, because digital impressions eliminate variables that inevitably occur in conventional impressions, like bubbles, distortions, etc. It is suitable for patients with deep undercuts, orthodontic and implant treatments, whoever has done a non-intended extraction of a tooth or a bridge knows what I'm talking about, or how to section the tray for 40 minutes straight. So it also provides diagnostics and patient oral health monitoring, including tracking the rate of tooth wear and tear. And I would suggest that if you have already an oral scanner, it's nice to have a digital impression of every patient that comes into your office, because it's a very good monitoring progress, for monitoring the progress. And also it is faster and easier to collab with other labs, and easier to check and analyze the impression quality as you have it there. Okay. So someone could say, okay, like I have the intraoral scanner, all I do is just move it around and take the impression, but that is not true. Some rules should be followed in order to take an accurate impression, and I'm gonna get a bit into the technique. So, saliva, blood, and liquids are all messing with the scan, so it is important for the mouth to be completely dry before taking an impression. In order to have an accurate margin, sometimes a gingivectomy must be made using different methods that my colleague Haritos also analyzed. Furthermore, sometimes the use of a cord with hemostatic agent must be used on the gingiva, but without damaging it. That means a correct size, preferably the smallest you can use, must be chosen. Otherwise, the patient can have a lot of pain post-operatively, and even a recession can occur. We need to be as much of atraumatic as possible and invasive. So the cord will retract the gingiva and will provide a visible margin for scanning. Also, the patient should not move and should be stable when taking the impression, and this is something that we will later also discuss. Afterwards, the scan file is sent to the technician, and the technician accepts and modifies it. Okay, so let's talk about one of the most important aspects of the lab, and something that most of you like, let's say. This includes the design. This step is made by the technician or the dentist, and is one of the most important steps in the workflow. This involves the first step of the design, the occlusion alignment. We need to check if it's correct. Milling of upper and lower jaw. And cervical margins and incisal direction. This is very important, because when looking at the outline of the preparation, especially in bridge works, everything should be visible. If they have a lot of angulation, this can be the worst nightmare of a technician and can definitely affect the final restorations. So with the use of digital dentistry, this has considerably helped the workflow, because in the past, lab technicians had to wax the tooth, then they had to cast it, then maybe it would break if the angulation wasn't correct. So this would take easily, like, it could take up to 2.5 hours to do it. Now with digital dentistry, it's like a 15 minutes work. You make sure that everything is correct, everything is ready, and it's easy. Shape and shade selection. So you select a shade, and you select a shape that already exists in the library, following the aesthetic criteria that my colleague Maria referred to. So you can design this tooth to match the contralateral, or if it's a new case, to match the aesthetic criteria. And also, like, this is a part where LENAS can come in place, LENAS part, because we know that different faces can have different aesthetics. So here you need to put also your gusto, anyways, your yes, your perception as an artist, in order to match these things. So afterwards, we have modification in interproximal contacts and distance from the antagonist and occlusion. So the occlusion has to do with a lot of factors. Firstly, the patient should not move while taking the bite registration because this completely messes it up. And many times patients do not close in ICP or close in a wrong position. And this can mess up the impression that we get. Here you can see, this is from a case. So when we have finished with this step, we send the file to the milling machine and we mill the desired material. So after it is milled, depending on what material it is, we go accordingly. Example, like zirconium needs to get in a sintering furnace for about 10, 11, 12 hours, because when it gets out of the milling machine, it's 25% bigger. So we need to do it appropriately, and afterwards we polish, we glaze, we polish again, and then it is ready to be sent to the dentist. The dentist cements the restoration accordingly. And this is a before and after case, all by using digital workflow. And here you can see we had a bit of diastema. Here it is reduced. And yeah. So this is an example of digital workflow. And as a conclusion, to achieve a harmonious aesthetic outcome, we need to bring together all of the components that were analyzed today. And this was the whole point of this presentation. We really hope you enjoy it. And I would like to thank the organizers for organizing such a beautiful and educational event. I would also like to thank my colleagues who did an amazing job in presentation. And Dr. Theocharidis, which he provided us with great bibliography, with some cases and a lot of guidance, which without this wouldn't be possible. Thank you very much.
Any questions? Okay, thank you.
Thank you very much, guys. Ευχαριστώ πολύ. Όντως.
Ευχαριστώ πάρα πολύ. Ευχαριστώ πάρα πολύ. Σ' άρεσε? Και του χρόνου, ναι, του χρόνου και καλύτερα πάντα. Improvement.
You were great.
Θα είμαστε όρθιοι. Νομίζω. Νομίζω να είμαστε όρθιοι.
Εγώ με τις κοπέλες δεν έχω απορίες.
Ελάτε να είμαστε όρθιοι.
Αυτό είναι το dental aesthetics. Ωραία τα είπες. Πολύ ωραία τα είπα. Και η Λένα, μπράβο, she arise from the dead. Έκαμε τα ούλα blend together. Αλλά έλειπα σε ένα slide. Ή ευκάλα. Εντάξει, καλά. Guys, let's pause. She said after you took the photo.
Ευχαριστούμε πάρα πολύ.
Thank you for organizing the event.
Ναι. Πώς τα πήγα, δεν το είδαμε, δεν το δω μετά όμως.
Τα πήγαμε πάρα πολύ καλά.
Μες στο workshop και δεν μπορούσα.
Το θέμα είναι πολύ πιο κατανοητό.
Ο δικός σας ήταν πάνω στο... Ήδη μπαίνει σε πολλά αντίκ.
Είχαμε διαβάσει πριν το σέρμα. Ήταν πολύ δύσκολο. Αλλά δεν πειράζει.
Λοιπόν, παιδιά, ευχαριστώ. Πάω μια τουαλέτα γιατί θα πεθάνω.
Ευχαριστούμε πάρα πολύ. Ευχαριστούμε. Να το στείλουμε μετά. Τώρα να...
Γιατρέ,
τώρα ευχαριστούμε πάρα πολύ.
Ότι σήμερα μπορεί από το δικό μου κομμάτι ήταν πλήρως κατανοητό.
ναι.
Ρε, δεν ήρθε κανείς και μόλις είδαμε θα μας
Το είπατε πολύ καλά.
Γιατί δεν ήρθανε.
Όχι, πλάκα το είπατε όντως πολύ καλά.
επειδή είχαμε μάθημα.
Ναι.
Εμένα μου το την φορά σε
Έτσι, μ' αρέσει να προετοιμάζουν άμα πρέπει να κάνω κάτι έτσι, ό,τι φύγει.
Άρα τα λέμε έξω.
Αλλά ας πούμε, άμα είναι να πάω σε ένα συνέδριο, ας πούμε, προσπαθώ στην αρχή να το διαβάζω, μετά προσπαθώ όπως περνά να μην το διαβάζω. Να πάω σε σοβαρό συνέδριο.
Αυτό κάνει το καλύτερο.
Το έχουν ανεβάσει, το YouTube ήταν live, δεν ξέρω αν μπορείς να το βρεις τώρα. Εγώ νομίζω θα αφήσουν, άρα θα μπορείς.
Αυτό προσωπώ και θέλω έτσι καιρό με καιρό να το κάνω.
Μπράβο, έβαλε πάρα πολύ δουλειά.
Θα το αφήσουμε αυτό να παίζει για flex.
Να είστε καλά.
Άιστα, πες. Άρα,
basically a break until 12:30. So like you can go and chill. Keep looking. Yeah. Όντως. Χριστέ μου. Αυτό σας έλειπε τώρα. Ναι, φυσικά. Θες το... Περίμενε.
Είμαι με το co-break.
Ναι, θέλει...
Ναι.
Δώσουμε το τσόκι, δώσουμε... Άσε δεύτερη. Άρα είσαι εδώ. Culture Center. Είναι όλους εδώ. Θα κάνουμε ότι θα τα βάσω τώρα βασικά. Θα ανοίξουμε και θα σας εξηγήσω για λίγο πώς λειτουργά και τι πρέπει να κάνετε και τα σχετικά. Και υπάρχει μια διαδικασία.
Τι διαδικασία?
Εσείς όχι, απλά. Όχι.
Θα πούμε και το live,
Αυτό. Γι' αυτό υπάρχει μια διαδικασία.
Δεν με πειράζει λίγο, βλέπουμε. Το μόνο μου.
Όχι. Ουφ. Τώρα κάνω αντού. Γίνεται αντού. Θα με σκοτώσω. Center. Άρα είναι εδώ η Ελένη. Είναι και αυτή η εσύ. Ωραία.
Μπορείτε να τσεκάρετε με τα νότα.
Ωραία. Τα notes δεν φαίνονται.
Τι εννοείς?
Είναι ο μόνος χώρος που δεν θα φαίνονται. Η μόνη σας επιλογή είναι ότι δεν θα το κάνετε hi.
Καλά.
Καλά.
Δεν το κάνω.
Ή δεν θα το κάνετε full screen και θα το κόψει πάνω όλα αυτά γιατί είναι live, άρα το κάνει αυτός. Άρα αυτό. Ή δεν έχεις βίντεο. Έχεις βίντεο. Τέλει. Άρα αυτό θα κάνουμε. Τώρα θα έρθει εδώ να θα εξηγήσει. Να έρθει να εξηγήσετε λίγο για τα notes.
Δεν παίζει περισσότερο.
Τι? Αυτό. Τέλει.
Θα φαίνονται και τα notes μου από κάτω.
Δεν θα φαίνονται, όχι. Επειδή το κόβει αυτός είναι... Το κάνει live stream, αλλά ξέρετε πώς το κάνει.
Αλλά δεν θα φαίνονται στο μεγάλο eкран.
Όχι. Όχι, δεν θα φαίνονται. Απλά εσείς, αυτοί που έχουν...
Δεν ενδιαφέρει.
Εντάξει, που έχουν βίντεο, απλά για να ξέρεις σκέφτηκαν κι άλλοι. Στέθηκα.
Έχει κάποιο βίντεο, δεν νομίζω ότι
Όχι, η προηγούμενη είχα. Γι' αυτό ρωτώ.
Αλλά ωστόσο θέλω να τσεκάρω το notebook. Γιατί μπορεί να εξετάσουμε.
Ωραία, όλα είναι έτοιμα.
Το δικό μου εδώ.
Φεύγει. Και το δικό σου μάτ. Ωραία. Απλά θα το έχεις έτσι και απλά θα αλλάζεις slides από κάτω. Και φέρνουν τα κανονικά. Απλά θέλω να ξέρω πώς θα το κόψω.
Εντάξει, μισό.
Εναλλακτικά να τους πω να το φέρουν
Δεν γίνεται να μεγαλώσουμε.
δύο πελάς που πάνω μας.
Αν το βάλω θα φαίνεται λίγο πιο μεγάλο, γι' αυτό. Τι λες. Και καλά στο slideshow φαίνονται flat screen, full screen τα ρόλια.
Ναι,
Δεν μπορούμε.
Ναι, είναι το, επειδή είναι live, είναι ο μόνος χώρος που δεν μπορούμε να έχουμε present notes. Γι' αυτό αναγκαστικά πρέπει να είναι έτσι. Ναι, είναι το μόνο θέμα του Cultural Center.
Εντάξει.
Όταν έρθω και θα περάσω και σε λίγο, όταν έρθουν οι υπόλοιποι, αλλά είσαστε έτοιμοι, τα πολλά ανοιχτά. Θα το πω και στους άλλους
Δεν
μετά.
είναι πρώτη, να ανοίξω το πρώτο μήπως.
Ναι.
Δεν τσεκάρω το μήπως το notes μου. Και όταν θέλω να κατεβάσω, έχω πιάνω το εδώ.
Ναι.
Θα κάνω με δύο δάχτυλα.
Okay. Yeah, just opening it. Did the notes work this time? No. He said that we cannot put it like a full screen. We don't have it presented here. We just have it like not full screen, and he puts the notes below, and he just cuts the screen because it's live. Yeah.
Ποιος θα μου φτιάξει το... Ποιος θα μου το έχει έτοιμο κάποιος πριν το μόνο με την έρθει.
Sorry.
Θα μου το βάλει κάποιος.
Όχι, απλά αλλάζετε τη screen. Δεν είναι κάτι.
Πώς το κάνουμε αυτό.
Αυτό.
Τι έκανες.
Κρύο δάχτυλα.
Α, εμείς πας στην αρχή αυτό.
Ναι. Ωραία. Και θα σας εξηγήσω και σε λίγο πώς είναι. Τι θα γίνει ακριβώς η σειρά και όλα.
Ναι.
Τέλεια.
Η σειρά είναι αυτό που έγραψε στο πρόγραμμα.
Ναι. Θα έχετε τον chair. Ο chair θα είναι αυτός που θα κάνει lead το discussion. Άρα θα έχουμε εμείς ένα μοτίβο που θα κάνει introduction chair και μετά από εκεί ο chair θα σας κάνει lead ποιος θα φάει πρώτος, ποιος θα φάει δεύτερο και τα σχετικά. Αυτό.
Δεν μπορεί ο chair να μας...
Τι?
Δεν μπορεί ο chair να μας το χέσει.
Ζητάς πρώτα.
Όχι.
Okay.
Thanks.
Yeah, so I think they're all
Έλα.
here. They're ready. We told everyone and the vibe is coming now.
Θα είναι έτοιμα όλα, οπότε όχι δεν σου πρέπει να κάνεις σκηνή τίποτα. Θα το κάνεις. Και δάχτυλα. Επειδή όλα είναι flat.
I've been there, by the way.
Και πόσο πιο... Ωραία. Δεν γίνεται να Δεν στα φάνουν αυτά, γιατί μπαίνει μετά το τέτοιο.
Κατάλαβα το να σε ρωτήσουμε κάτι για το λάπτοπ. Ναι, ναι.
Ούτε εδώ θα φανεί. Θα μιλάω και θα είναι σαν ηλίθεια.
Μπορείς να το βγάλεις. Μπορείς να το βγάλεις να χρειαστεί.
Τι εννοείς?
Και καλά να μην το κάνεις να μην δέχεσαι. Θα το παίρνω λίγο.
Έχεις εσύ. Είπα στο κοινωνικό μου, δεν με πειράζει.
Το βλέπεις.
Δεν είναι πολύ σημαντικό. Μπορεί να γίνει. Έχεις iPad.
Μόνο το λάβω και κάνω.
Μπορείς να αν το κάνω screen, ξέρω εγώ. Θα είναι πολλά slides όμως. Καταλάβω. Για παράδειγμα, εδώ. Αν βάλεις αυτό το πράγμα που μου καταλάβω. Εδώ έχω βίντεο. Όχι, αλλά έχω άλλες φωτογραφίες. Καταλάβες,
Εντάξει, σημαίνει θα σου στενός. Τι μπορείς να κάνεις οι προηγούμενοι και κάμαν απλά copy-paste και είχαν τα και τυπώσαν τα. Έτσι τα κομμάτια, μισή ώρα να το κάνετε, παίρνουν και τυπώσαν τα στο πανεπιστήμιο ή έβαλαν τα pasta notes και είχαν το κινητό και τυπώσαν από κινητό.
το κινητό δεν έχω. Θα το κάνω έτσι, θα είναι περισσότερο slide απλά.
Αυτό το κάνουμε. Αυτό το κάνεις έτσι. Όπως θέλετε. Οι προηγούμενοι πάντως τυπώσαν. Είχα και εκεί μισά ώρα πριν, είχαν και νωρίς, τυπώσαν.
Okay, thank you.
Είναι το θέμα του cultural center που ελευθερώνουν τα notes, επειδή είναι live.
Γεια σας.
Καλά, εσύ.
Κάτω την έχει. Είστε έτοιμοι?
Απλά για να σας ενημερώσω, εντάξει, είναι πολύ καλά. Έχουμε ήδη, είναι όλα έτοιμα. Όταν είσαστε έτοιμοι χρονικά, γιατί είναι live, θα πω το πίσω, είμαστε live για να ξεκινήσει, γιατί κάνει live stream. Τα presentations είναι ήδη ανοιχτά και έχουμε εμείς κάποιον από την ομάδα που μας κάνει introduce και μετά απλά εσείς μπορείτε να κάνετε.
Ωραία. Εγώ, τι πρέπει να κάνω, εγώ θα μου πεις.
Κανονικά και στο μήπως είναι η σειρά πάνω στο πρόγραμμα.
Όχι, εγώ είμαι... Εγώ δεν παρουσιάζω.
Ναι, είστε η chair.
Ναι, οπότε δεν θα πω... Ποιος είναι, θα τους παρουσιάσω εγώ πρακτικά, ότι και το περιστατικό, θα έχω το πρόγραμμα μπροστά. Θέλω να ρωτήσω, κρατάμε timer, χρόνο, θεωρητικά. Εντάξει, το αφήνουμε, δεν δίνουμε σημασία.
Απλά ναι, θα λέτε φυσικά εσείς την σειρά, σας το δώσω και τώρα, για να ξέρετε πώς θα είναι. Απλά για να ξέρετε εσείς θα σας κάνουμε εμείς την introduce για να ξεκινήσετε κανονικά να κάνετε τους υπόλοιπους introduce που θα κάνετε.
Στην κάθε φορά που θα παρουσιάζουν, ποιοι θα παρουσιάζουν.
Και free takers είστε... σήμερα... εδώ.
Έχετε κάνει πάρα πολλή δουλειά. Θα υποθέσω ότι είσαι από την ιατρική.
Ναι.
Και σου μιλάω στον ελληνικό, δεν πειράζει.
Απλά ότι άλλα θα είμαι εδώ, θα πάνω κάτω.
Θα μου πεις μόνο το όνομά σου.
Πολύνα.
Πολύνα. Οπότε στην ουσία είμαστε τώρα... Είναι αυτά εδώ... εγώ βλέπω το Culture Center είναι αυτά εδώ. Οκ. Εντάξει. Αυτά τα 5. Ήδη μέσα είναι όλα ένα. Οκ, να ρωτήσω κάτι. Πρέπει να πούμε όλα τα ονόματα. Εδώ έχει μόνο τα ονόματα των παιδιών που παρουσιάζουν.
So welcome to the first free paper presentation session. This session will be chaired by Dr. Konstantina Taufik, a lecturer at EUC that specializes in pediatric dentistry. I will now give the floor to Dr. Taufik.
Hello to everyone. Today we are going to have a dentistry session, and the first presentation is from Efthemis Karagiannis and is about the management of early interproximal and buccal caries in a teenager with resin infiltration. So Efthemis, you can come and start with your presentation.
Okay. So, hello. Today, obviously, as Dr. Taufik said, we'll be talking about management of early caries in a teenager with resin infiltration. It was a case that happened here in the clinic of the Department of Dentistry, which Dimitris, shout out to Dimitris, and Dr. Kavadia dealt with. So, beginning with some background information, our patient was a 12-year-old female with a presenting plane of extraoral swelling on the right side. In terms of general medical history, we have no underlying medical conditions and a non-contributing medical history. In terms of her dental history, she brushed only once per day, and as far as we know, it was her first dental visit. Now, the intraoral findings were gross plaque, a lot of plaque calculus present, very poor oral hygiene due to the infrequent brushing, and as a result, we did have a lot of generalized gingivitis and a decent amount of early carious lesions, especially labially for the anterior teeth. Now, going to our little Hollywood star. Obviously, this happened after we dealt with the extraoral swelling. Specifically, this photo was taken after we had finished an occlusal filling on tooth 26, and as you can see, there is a brown spot, buccally and distally, in the interproximal region of the molar. Now, we had three main options of how we're going to deal with it. Number one being leaving it as it is, giving appropriate oral hygiene instructions, and then monitoring, which it was not really an option, considering that the oral hygiene was already poor, and we would need to do a conventional filling on it either way after some time. Second option would be to apply some fluoride, which would help a bit. It's a bit more proactive. The tooth would be fortified for a bit, but again, it would not be as long-lasting. And the third option that we obviously went with was resin infiltration, specifically using ICON. Now, ICON is a very conservative technique, and it can be used for managing initial caries. How it works is that it fills the pores of the demineralized enamel, and it prevents further acid attacks. So, how we did the technique? We initiated with an acid placement of hydrochloric acid for 120 seconds. If that sounds like a lot, it is just because it is. We just want enough time to break through the first layer of hypermineralized enamel and dissolve all the pores of the enamel defects. We proceeded with 30 seconds of rinsing, and then we added a desiccating agent, in this case ethanol, for 30 seconds. We desiccated again completely, and we started with the initial resin placement for 180 seconds. This happens incrementally, so we slowly add resin until it is completely filled. We then polymerized for 40 seconds, and then proceeded with a secondary placement for about 60 seconds, with further polymerization for about 40 seconds. Now, on the top left, you will see that after curing, the carious lesion has subsided significantly. It hasn't completely gone, but it's a lot better than before. There are some excess resin infiltrant, which we later polished, as you can see on the right. And on the bottom of the screen, you can see the 3-month reevaluation. So what we see is that basically there is no lesion advancement. So analyzing the strengths, weaknesses, opportunities, and threats of this specific case, The good thing is that it was minimally invasive. We didn't have to do any drilling. We didn't have to do anything, honestly. It was very efficient in dealing with early caries, and the lesion did not advance. It did have an aesthetic effect on the defects of the enamel, and it worked whether or not, it depended actually of whether the patient actually improved their oral hygiene or not. In this case, they did. Even if they didn't, it still would have a decent result. And for what it does, it's a very fast procedure. Now, the weakness is that it is expensive. I think it's about 25 euros per tooth cost to the dentist. And that's mainly because it's a patented technique and a product. There's no other options. And also because of that, we also have limited evidence backing the use of it and its efficacy. Another bad thing about it is that, again, we do have 2 minutes of just hydrochloric acid being in the mouth, which is never a good thing. And we also need a very good tooth isolation. So avoiding anesthesia, clamps, and stuff like that is not a thing that we can do. Now, again, in terms of the opportunities, it's minimally invasive, and we avoided the incremental tooth structure removal, meaning that if we did a conventional filling, after, let's say, 5 to 10 years, we would probably have to do another one. By doing another one, we would have to remove the filling that we had, any carious tissue, and then a bit more just to be safe about it. So we keep destroying sound tooth structure over and over through the course of the years. Again, we don't need to do that with Icon, so we prolong the tooth life even more. In terms of the threats of this specific, let's say, technique, Icon is very abrasion sensitive, so flossing, the distal tooth erupting, brushing and stuff like that will abrade it to the point where we will need to do it again, so we need to do reevaluations constantly. After some time, due to the resin itself, there is some discoloration noted by some people. Teeth tend to get yellow where the resin is placed. And obviously, if the isolation is not good, or we somehow drop the acid onto the rubber dam, it could burn through and then cause hydrochloric acid burn on the gingiva, which is never a good thing. Now, this is the body of evidence for the use of Icon, and more specifically, we do know that resin infiltration in combination with non-invasive treatments is more efficacious than non-invasive treatments alone in treating proximal caries, both in primary and permanent teeth. We do know that progression of proximal caries was less likely to occur in permanent teeth with resin infiltration and oral hygiene measures compared to just non-invasive methods. Resin infiltration of proximal caries extending up to the enamel dentin junction, which is R2, maybe a bit of R3, in terms of radiological grading, is effective in reducing lesion progression after an observation time of 7 years, which is a decent amount of time. However, we do need to do further investigation in order to check whether we can improve this technique, modify it, and see if there are better results that we can get. And if we can also eliminate all enamel opacities. Also, in terms of the aesthetic region, aesthetic caries infiltration can mask post-orthodontic initial caries for at least 6 years. These results can not only be observed by quantitative, but also qualitative analysis. So, some concluding remarks. It's important to follow evidence-based dentistry. The body of evidence is not a lot, but it's still pretty solid, and it's important to follow it. We should note that this technique is pretty effective for what it does and for the invasiveness of it. We do need to note that there is a need for frequent reevaluation. It is a very good and intriguing option for arresting interproximal caries, and it's a very good minimally invasive technique to add to our armamentarium. That's it. Thank you for your attention. Any questions?
Okay, I have a question. I wanted to ask if when you're going to graduate, and you're going to start working as a dentist, if you're going to use icon as a treatment modality and in your daily practice or not, and why?
Personally, I would use it. I think the patent expires in a couple of years, so we're going to see more people than just more infiltration products than icon, so it's going to be cheaper. Obviously, it's minimally invasive, so again, that's what we need to do as dentists. We need to preserve tooth structure, not just remove it and then replace it. So yeah, I would definitely do that.
So you're going to use it. If you didn't use it in the clinic, do you think it would be harder for you to try and use it afterwards?
Yes, yes.
So, okay, so that's a good thing that during your clinical practice you're going to learn new techniques, new treatment modalities, and these will help you to use them after you graduate. So the next presentation now. Sorry, we have a slight change in the program. We are going to have the presentation of lateral incisor vertical enamel groove in a 10 years old management and 12 months follow-up, and the presenter will be Eleni Fouli.
Okay, so good afternoon. My name is Eleni Fouli, and we had this case with Aviva Singer, my partner. I'm a 5th-year dental student, and we had a case of a vertical enamel groove management and the follow-up in an 11-year-old child. So this is the outline of our presentation. So we had an 11-year-old child. She was a female weighing 43 kilos, and she came with her mother to our clinic. And the main complaint was that she has a spot on her front tooth that does not like. So concerning the medical history, the general health was non-contributory. The pediatrician relationship was positive. She was vaccinated up to date, and her mother had a normal full-term pregnancy. We didn't have any history of viral diseases nor fever. We didn't have any allergies or medication. And she has been hospitalized once she was 7 years old for gastroesophageal disturbances. And concerning the family history, we only have diabetes from the mother's side. So the dental history. Her last dental visit was in November for the follow-up. She has a previous dental experience, and she reports that she brushes once per day with a fluoride-containing toothpaste without any other means. And we didn't have any oral symptom, any dental injury, or any paranormal habit. The pediatrician interactions were also positive. Since she was cooperative, we gave her a Franco scale of 3 to 4 because she could follow instructions and she was quite cooperative. So this is a clinical picture. As you can see, there is the groove on the enamel on the buccal side on tooth 12. Palatally, it wasn't that noticeable, but buccally was. So we had a vertical enamel groove on the buccal surface of tooth 12. It was extended into the gingival sulcus, and we also had some mild gingival hyperplasia cervically. Palatally, it was a very shallow groove, and we also had gingivitis on that tooth associated with the groove. No other teeth had any other defect, and perhaps her dental age is compatible to the chronological age of the patient, and we didn't have any caries. This is a panoramic. We didn't take a periapical X-ray, since from the panoramic it was quite obvious, and we wanted to have a general idea, and you can see clearly the groove. So we did a problem list. First of all, we had the groove. We also have a high risk, moderate to high risk for caries. Her oral hygiene was poor to fair, and we had generalized mild gingivitis and localized moderate gingivitis on tooth 12. So we did the diagnosis, which was enamel hypoplasia, which is a quantitative defect, and hypoplastic enamel defects result from changes that happen during the stage of tooth matrix formation. So to summarize, we had a solitary vertical groove buccally on the enamel. It was consistent with localized enamel hypoplasia on tooth 12, extending into the gingival sulcus with moderate gingival hyperplasia cervically. So we came up with a treatment plan, which was to restore the groove using composite resin. So in general, when she came, first of all, we did the clinical and the radiographic examination. We had a full mouth debridement, and we also applied topically fluoride. We gave her very good oral hygiene instructions, and we restored the groove with composite resin. And we had a follow-up of 2 months, 6 months, and a yearly follow-up. And in the yearly follow-up, we also did some sealants. So this is a picture. As you can see, this was while restoring tooth 12 with composite resin. We chose the shade A2. And these are the pictures after the follow-up after 2 months. We have aesthetics. The cervical contour was smooth, but we also had still some mild gingivitis cervically. After 6 months and after a year, we also had another follow-up. And in both cases, aesthetics maintained and gingival health was getting better. So what could have happened if she was left untreated? First of all, her oral hygiene will get more and more compromised. We will have caries, gingivitis, bleeding, and gingival hyperplasia, and also aesthetical problems. The groove will get worse, maybe some discolorations and some tooth sensitivities also. So we also did the reflection of the case. We have as advantages that we have aesthetics and function, and the patient was happy. But we still had some gingivitis, and we could have used a preliminary restoration with glass ionomer before placing the final restoration. Why? Because we want to allow the gingival health to restore, and we need to implement stronger oral hygiene measures. We also did the SWOT analysis, which stands for strength, weakness, opportunities, and threats. As a strength, the defect could be easily restored. The patient was cooperative. She could follow the instructions, and she was happy after it. But we had compromised oral hygiene, and the defect was extended into the gingival sulcus. But we had the opportunity to learn more about these defects and how to treat them, and how to use interim restorations to allow the gingival healing. But as threats, we have the caries risk, which was moderate to high. Future complications, for example, staining of the composite. So at the end, we ask ourselves, what will I change if I were to manage this case again? We could have used resin-modified glass ionomer as an interim restoration in order to allow the gingival health to restore before. And of course, electrical toothbrush could have helped her to improve her gingival health, especially in the cervical area of tooth 12. So that was it, thank you. And here you can scan it for our references. Thank you.
Do you have any questions? Dina.
Yes. A retraction cord was placed. There was no need for a flap because it was before the bone. So we could have actually access. And we also used the rubber dam, but with the gingival cord it was okay. And because she could follow instructions, her oral hygiene was getting better because we didn't do that at the first appointment. We did it after. So at the first we did the x-rays, we gave her the oral hygiene instructions, and then we saw that there wasn't difference. In that case, we used it because we wanted to have access, because it was extended into the gingival sulcus. Okay, anything else?
It is indicated for those cases, and I have another question. Do you think that you could ask her to have more frequent recall visits?
We did first after 2 months, then 6 months and the year follow-up. But because in 6 months and in a year we saw that there was a difference, and actually the aesthetics were maintained and her oral hygiene was getting better, it was enough. But if we saw that there was no difference, of course, yes.
Are you going to alter that when she will be a pubert?
We will see accordingly. If, for example, there is staining, or if there is a need to do improvements, yes.
Okay. Any other questions? No? Thank you very much.
Thank you.
Okay, now the next session is from Nefeli Katanaki. She's going to present the prevalence of congenitally missing permanent teeth in a sample of orthodontic and non-orthodontic patients.
Ladies and gentlemen, good morning. Today, we will present the results of an investigation regarding the prevalence of congenitally missing permanent teeth in a sample of orthodontic and orthodontic patients from the island of Lesbos. Congenitally missing permanent teeth constitute an important clinical and public health problem. A lack of the initiation stage of tooth development in the dental lamina results in the absence of a single or multiple teeth. Hypodontia is one of the most commonly occurring developmental anomalies. Prevalence is 3 to 10% in the permanent dentition, excluding third molars with a 3 to 2 predilection in females versus males. American blacks have a significantly lower incidence of missing teeth. Congenitally missing permanent teeth are usually identified in early childhood. The first evidence of missing permanent tooth may be an over-retained or submerged primary tooth confirmed with radiographic examination. The etiology of non-syndromic and familial congenitally missing permanent teeth is unidentified and multifactorial. Genetics play a fundamental role in the etiology of tooth agenesis, with more than 200 genes involved. Genetic mutations are often associated with hypodontia. Mutation of the axin 2 gene is inherited as an autosomal dominant disorder. More than 50 syndromes exhibit hypodontia as a major feature. These include ectodermal dysplasia, Down syndrome, chondroectodermal dysplasia, Rager syndrome, craniosynostosis syndrome, incontinentia pigmenti, orofacial digital syndrome, and Williams syndrome. Congenitally missing permanent teeth can affect the stomatognathic system in various ways. They can influence the position of their antagonists and adjacent teeth, alter the occlusal function and relationship, and cause aesthetic problems and asymmetry. The treatment represents an interdisciplinary challenge that includes specialists in oral surgery, operative dentistry, orthodontics, and prosthodontics. The aim of the study was to investigate the prevalence of congenitally missing permanent teeth in a sample of orthodontic and orthodontic patients. The panoramic radiographs of children 9 to 16 years old attending orthodontic and general or pediatric dental practices were reviewed. The orthodontic and orthodontic samples originated from a bigger sample constituting from 590 and 119 children respectively. The inclusion criteria were that both parents to be native Greeks originating from Lesbos and good quality and clarity of panoramic X-rays. The exclusion criteria were children of economic migrants, foreigners, military or public servants transferred to Lesbos. Possibility of extracted permanent teeth because of caries orthodontic reasons, syndromes and conditions like ectodermal dysplasia, cleft lip and palate, etc. Now, the orthodontic and orthodontic groups included panoramic radiographs of 521 and 100 children respectively, with a mean age of 12.5 years old. The total sample composed of 258 males and 363 females. The prevalence of congenitally missing permanent teeth, excluding third molars, was determined. Patient records in the orthodontic sample were reviewed as well to exclude the possibility of extracted permanent teeth because of caries or orthodontic reasons and to record Angles class in the orthodontic group. Descriptive statistics were calculated and the comparison of the prevalence of children or teeth exhibiting congenital absence between the two groups was performed with SPSS software. The prevalence of congenitally missing permanent teeth was 5.5% in the orthodontic, 14 males and 15 females, and 4%, 1 male and 3 females, in the non-orthodontic group. In the orthodontic sample, 3% were females and 1% were males. In the orthodontic sample, it was found a percentage of 5.5% of missing teeth, with 2.8 corresponding to females, 2.5 to males. In the orthodontic sample, 20 lower second premolars, 12 upper laterals, 7 lower central incisors, 2 lower canines, 2 upper second premolars, and 2 lower second molars were congenitally missing. In the non-orthodontic sample, 3 upper laterals and 2 lower second premolars were found congenitally missing. Overall, no statistically significant differences were noted between the two samples regarding the number of children with congenitally missing teeth or the type of teeth absent. The review of patient records in the orthodontic group showed that 10 of them exhibited an Angles class 1, 18 a class 2, and 1 a class 3 malocclusion. In the present study, the prevalence of congenital missing teeth was approximately 5%. In a sample of Greek children with malocclusion, the prevalence was 8.4 with female predilection. Similar numbers have been reported by international studies with a prevalence of congenitally missing permanent teeth ranging from 4.5 to 6.5%. Regarding the type of teeth congenitally missing, the most commonly absent teeth were the mandibular second premolar and the mandibular laterals. In the study of Greek children with malocclusion, the same types of teeth were reported most frequently missing are similar to those. Conclusions have been reached by the information originating from meta-analysis of international studies. The absence of different teeth can be affected by the ethnicity, the sample types, epidemiological or dental patient, sample sizes only in the case of second mandibular molars, and the minimum ages of the investigated subject only in the case of the maxillary lateral and the mandibular second premolar. Finally, the conclusions from the present study are that in the specific sample originating from the geographic area of Lesbos Island, the prevalence of congenitally missing teeth was approximately 5%. The most commonly absent tooth was the lower second premolar. Last but not least, no statistically significant differences were noted between the orthodontic and orthodontic groups regarding the number of children with congenitally missing teeth and the type of teeth absent. Thank you very much for your kind attention. Any questions?
I have one question. I wanted to ask you, now you said that the mean age of the group was around 12 years old. Do you think that probably we should, as dentists, ask for a panoramic X-ray at earlier ages so we can detect congenitally missing teeth, which might, if it happens at an earlier age, might alter the treatment plan, the orthodontic treatment plan?
That's a nice question, but if we can justify the panoramic radiograph for another reason, probably we could do it, but like having the child to undergo the radiation just for preventive reasons, I don't think that it could apply to all the cases, only for the absent teeth.
So maybe it's good to have a good collaboration with the general dentist, the orthodontist, and the general dentist, and decide to see if any alterations or changes in the eruption pattern exist, to be able to decide when to do panoramic X-rays.
Yes.
Thank you. Any other questions?
Can I ask?
Do you think, no, it does, yeah. Do you think it would have added anything to your study if you have included panoramics from the parents as well to evaluate missing teeth, since you talked about genetics in correlation with this?
Yeah, if we had studied the panoramics, if they had, I probably would see like the correlation, if like the gene is transferred from the parents, if they had an absent tooth, that would be transferred to the child, the absence. So maybe we could see like the genetic correlation to the absent teeth.
So that's a good point for your next research.
Thank you.
Okay, next presentation is from Elena Santi, and she will present dental enamel defects in a 12-year-old female, differential diagnosis.
So, hello everyone. Me and Jana, we worked on a case report of a teenager, 12-year-old female with dental enamel defects. And today I'm going to present the differential diagnosis. So, developmental defects of enamel in multiple teeth occur more often in chronological enamel hypoplasia and amelogenesis imperfecta. These defects pose aesthetic concerns for the patient, but also challenges to the dentist regarding adhesion of aesthetic materials, depending on the type of the defect. In terms of the medical and dental health of our patient, her general health was non-contributory. She had no history of viral diseases and fever, and not known allergies. She was briefly hospitalized twice at the age of 4 years old, due to upper respiratory tract infections treated with inhalers and antibiotics. Her last dental visit was 3 years ago, and her oral hygiene is considered poor due to the occasional toothbrushing and because she didn't know whether her toothpaste contained any fluoride, and she didn't use floss or mouthwash. There was no family member with similar dental defects, and she was consuming more than 3 snacks high in sugar and carbs. Those are the clinical images taken at her initial appointment. You can clearly see the enamel defects occurring as horizontal thin grooves and pigmented pits on the buccal surfaces of her anterior teeth, and the multiple carious lesions mostly on her posterior teeth and some on her upper anterior teeth palatally. Then we took 2 bite wings to assess the carious lesions, and as you can see, she had some deep ones. Then we took a panoramic X-ray in order to assess whether the defects were symmetrical throughout all the teeth, and the radiographic findings were horizontal radiolucent grooves along the cervical line of the lower teeth extending from premolar to premolar, enamel hypoplasia, and possible torodontist on her molars. Those are the 2 odontograms we made. In green, you can see the teeth affected with enamel defects, which are almost everywhere in her dentition, and in red, the caries. The problems she had were possibility of enamel defects, aesthetic concerns since she was a teenager, poor oral hygiene, orthodontic problems since she had class 2 malocclusion and crowding on her anterior teeth, many carious lesions, and sensitivity to cold on tooth 46. So what are the facts of our case? After clinical examination, we concluded that there were 23 teeth affected with enamel defects, occurring as pigmented pits on the upper anterior teeth and as enamel grooves on the lower canines and premolars, although she didn't have any sensitivities from the defects. After the radiographic examination, as mentioned before, we observed horizontal grooves extended from premolar to premolar, and regarding the history, we found that there was no family history of such defects. The siblings which were examined in the UC Dental Clinic had no defects except her sister, that she has MIH, but is not correlated with our case. Also, after seeing photos of her primary dentition, we concluded that it was a defect present only on her permanent teeth. So, after the previously mentioned investigations, we concluded in the differential diagnosis of amelogenesis imperfecta and chronological enamel hypoplasia, which are disorders that affect the clinical appearance of enamel. The table shows characteristics that are present in each defect, and regarding our case, she had enamel defects in both anterior and posterior teeth, which is a finding of amelogenesis imperfecta, because chronological enamel hypoplasia affects only a single or groups of teeth developed at similar time of development. Moreover, she had enamel of reduced thickness, which is something common for both defects. The surface of her teeth was rough, pitted, and grooved, and she didn't have open bite. On the other hand, we are not sure if it's associated with any medications or sickness during childhood. The most reliable database to assess in general genetic disorders is OMIM, which is an online catalog of human genes and genetic disorders. And after searching the main findings of our case, in OMIM, the most probable diagnosis was amelogenesis imperfecta, as you can see here. Then we used this diagram, the Atlas of Human Teeth, which is showing the time that the teeth are developed and erupted. And in order to identify whether the defect is chronological origin, but as we said before and we can see here, there were 23 teeth affected and not a specific group of teeth that was developed in a specific time. So possibly the insult of the ameloblast was constant, but gene analysis must be conducted to confirm the definitive diagnosis. Regarding the treatment now, after restoring the caries, we proceeded with the restoration of enamel defects. Here you can see the initial photograph, how her teeth were when she first came in the clinic. We chose to start by using sandblasting machine to remove the pigmentation, and this is the result immediately after, but the pigmentations were not completely removed, and since we wanted to be as minimal invasive as possible, we used the smallest bird to prepare a bit the pits. We first chose the color, and then we acid etched with phosphoric acid, cleaned and dried, and continued with the use of bonding agent, and then we placed the composite in layers. Here you can see the final result. Furthermore, customized prevention program was provided to the patient in order to maintain oral hygiene. Relevant literature support that the most important part of the management of those kind of cases is to determine the appropriate diagnosis of enamel defects, and other problems that patients with amelogenesis imperfecta face are lower self-esteem, social avoidance, negative psychological outcomes, and high cost of extensive restorative care. The longevity and quality of composite resin restorations in patients with amelogenesis imperfecta are shorter than in patients without any dental defects. Then, in order to reflect on our case and improve on our outcome, we did a SWOT analysis. The strengths were addressing patients' concerns and improving her self-esteem. The weakness was the uncertainty for the appropriate technique to prepare the enamel surface. The main opportunity we had was to expand our knowledge on enamel defects, and the threats for the future are the aging, possible failure, and discoloration of composites, both affecting aesthetics. And in case of bracket bonding, there is possibility of enamel chipping when debracketing, and possible caries, since she's a high-risk caries patient. Thank you so much. Do you have any questions?
Yes, we can ask. Why did you exclude fluorosis from your differential diagnosis?
Because you can see that her initial photograph, she had pits and grooves, and in the fluorosis you can't see those kind of anatomy. It's more like for enamel defects, not correlated.
Change color?
Mm-hmm.
But you said the color did not go away after you did some.
The pits, yeah, because it was deep, and she had it from a while, so.
It has to do with my question. I wanted to ask, do you think you can do sandblast in a non-cooperative child? Will it tolerate it?
I think it's a very easy procedure, actually. I think we can do it, but it depends also to the dentist if he can control a bit the patient. But it's an easy procedure in general.
So, do you think you can control the patient?
Me, personally. In general, I think some dentists can do it. They can't control the patient, but if it's difficult...
I'm just asking to say that as your instructor, I know that you can all do that.
Okay.
So it's a compliment.
Thank you.
Do you have any questions that you wanted to ask? Okay. So,
Thank you.
I thought that this microphone didn't work. That's why I was getting up. Now, the last presentation is from Dina Yakub, and she's going to present a rare case of an erupted odontoma in the primary dentition.
Does it come alone?
I think.
Oh, yes. Hello, everyone. So I'm going to start straight away with our aims of this presentation is to show you a very rare case from our EUC dental clinic, pediatric dental clinic. So today we will discuss what is an odontoma. We will try to categorize it, and we will talk about the clinical management. Then we will present the case, and we will talk about some future implications. Odontomas. Odontomas are benign odontogenic tumors, which are tumors that come from teeth. They come from fully differentiated epithelial and mesenchymal cells, which eventually become dental tissues. We don't really know why odontomas happen, but we have some idea. Some people correlate it with local trauma during infancy, or infections, inflammatory, or even genetic conditions, such as Gardner syndrome. Odontomas are very common, around 22%, but we only find them accidentally during routine radiographic examination. In pediatrics, so in primary teeth and baby teeth, the first odontoma was reported in 1949. In 1949, we thought odontomas were not able to be formed in primary teeth. But a few years later, the first case was reported. Now, odontomas can be classified into two types, either histologically or clinically. Firstly, histologically, odontomas are two compound which are organized in an orderly manner, as we can see in figure A. Complex ones, figure B, which are the mass is organized in an irregular manner and it doesn't look like teeth. Clinically now, we have three types: intraosseous or central, which is the most common, and it's usually in the bone, hence the name. Peripheral, again, hence the name. It comes from soft tissue. It's pretty rare, same as erupting, also pretty rare, and they are usually ones that are intraosseous and eventually become erupted into the oral cavity. Now, the treatment for odontoma is pretty straightforward. You either monitor or you remove. Our case now is about a 5-year-old female patient who presented to us for the first time. It was her first visit. She came with her dad. But although she was pretty young, she was very cooperative. As we can see from the medical and the dental history, there was no significant findings, except for the patient was adopted, so we had no information about genetic, for example, or pregnancy or delivery of this child. Then we did our intraoral examination, and you see what we saw. There was some attrition, caries lesion, and most importantly, the small calcified mass. Taking a closer look at it, this is what we saw. I hope you can see it clearly. It was hard, immobile, no periodontal involvement, and yellow. Then we decided to take a small periapical radiograph, and the most important finding here was the bone resorption associated below the mass. Again, I hope you can see it. Then we brainstormed those 7 differential diagnoses, but always the final diagnosis comes from histopathological analysis. Therefore, this was our treatment plan: excise the mass and send for histopathology. After we have confirmed and approved and consented this procedure, because this is a very important thing in pediatric dentistry, because parents tend to always change their mind about those things, reviewed the medical history, we administered profound local anesthesia, and with the help with Dr. Diamandi, we removed it. Then the mass was inserted in some liquid, and we sent it for histopathological analysis. A few weeks later, the diagnosis was confirmed to be a compound odontoma.
Now, we thought about what if we chose not to treat this patient today if the patient never presented to our EUC dental clinic. There's a lot of cases reported about odontomas increasing massively in size, causing malocclusions, hence orthodontic problems, possible impactions of permanent dentition, or even inflammation, infections around the mass because the oral cavity is filled with bacteria, saliva, things come in and out. Or even worse, the mask could exfoliate and the patient could swallow it or even inhale it, and that's a different problem. Now, we also thought about, we went to the PubMed mainly, and we searched how rare is our case, because we usually know that odontomas are inside the bone. We see them on the radiographs only. So there's around 1,200 cases of odontoma reported in the English literature, same number of compound and complex. And there's only one case of an erupted odontoma and permanent dentition that is not associated with unerupted tooth or a missing tooth. And even rarer, there's only 16 cases of primary odontomas in primary dentition, as we saw in our patient. And 12 of those are also non-erupted intraosseous odontomas. Therefore, this is the first and only case in the literature concerning erupted odontomas in primary dentition, up to our knowledge in English literature. So our take-home message today, we all now know what's an odontoma, I hope, and how rare this case is, and also that we want to emphasize that the rarity of this case is not necessary because of the lack of its existence, but because we don't have children coming into our dental practice, to the pediatrician, or even to the general dentist that often. Dentists also lack the need to do thorough examinations. They don't really do it so much, neither do they do biopsies. So this is another problem. And it's very important for children to frequently visit the pediatric or the general dentist, recommended by the age of 1 for early diagnosis of such conditions and to prevent other problems. Also, such entities, they always need histopathological examination to confirm our definitive diagnosis. And finally, we have an unknown actual prevalence of erupted odontomas in primary dentition because almost everyone classifies clinically odontomas differently. So we don't have a strict, concise a classification, neither do we learn this type of classifications. So we are in need for a new categorization of clinical diagnosis of odontoma. Thank you. These are references. Any questions?
Do you have any questions? It is one of the cases that I was responsible, so that's why I'm asking if you have any questions. I don't know if it would be fair to ask, but I can ask. So what was the hardest thing during your pub search regarding this case?
The hardest thing was to diagnose this because, okay, we found histopathologically it was a complex odontoma, but was it originating from the bone or from the soft tissue? But we even had a lot of, because Dr. Taufik, she's our supervisor, we had a lot of arguments about it. We would go one day and then we would change our mind and we will change the diagnosis every week. But finally, we realized because of the bone resorption, it can be nothing else but intraosseous erupted odontoma.
So practically, we couldn't classify it because there are not enough data in the literature, and in some cases, not in primary dentition, but in permanent dentition and in adults, they said that this was erupted odontoma. In other cases, the same entity was called as something else. So we didn't know, and that's why we decided to try to make a logic classification, and we are going to propose that. Any questions that you might have? No. So now we finish with our session. The only remark that I wanted to say is that I would like to congratulate all the participants and all the others who supervised or who assisted, because those presentations are not only the work of the presenters, other students have also contributed to them. So I would like to congratulate them all. And I would like to tell you that I'm proud of your presentation and for the work that you have all and the effort you have given to make those presentations today. So thank you. And I'm certain that you're gonna participate in many congresses, and that you will always do a good job.
Hello everyone, I am Rafaelia. I am here to welcome the Exploring Postgraduate Pathways workshop. Our first speaker is Dr. Emmanuel Nicolusis, the acting chairperson and associate professor of hematology at European University.
Thank you very much, Rafaelia. So exciting times, postgraduate studies. So the most difficult part, you'll often find that university has been a piece of cake compared to what you'll find in front of you. You can see that healthcare is becoming more and more demanding, and I suspect that you've seen what happened during COVID and how important is healthcare services across the world. Before, 20 years ago, you would say you'll graduate and then you'll find yourself in a hostel, whoever is actually going to Greece. There's a process called agrotikon, which is like a service, a healthcare service in the rural areas of Greece. So, I did that in 1997, and I must admit, sometimes I was completely lost, because as you will often find, clinical training during university does not give you all the essentials to go through the first paths of your career. However, things have changed now, and if you pursue a career in medicine, it doesn't necessarily mean that you'll go down the clinical setting, and there are other options as well. Certainly, the majority will go down the clinical setting, and you will start by going to a hospital where you will become like a junior trainee. I've done my career after the medical school and after doing this rural service that I had to do for Greece. It didn't pay me back because it actually forced me to leave the country. That good was the healthcare service provision in Greece. So I ended up in the UK, where you have a much more structured pathway for training. And I must admit, when you follow your clinical paths, the first thing you will need to focus on is where you will actually get the best training. Why am I saying this? Let's say that you follow a surgical specialty and you go to Greece. The chances of going through operations as a trainee, as a surgical trainee, is minimal, if any. Okay? So you'll end up doing a fellowship somewhere else in another country to try and gain experience, because as a trainee, there's no structured, as we say, observation of how well you progress through your training. So let's say that you're a surgical trainee. You will start by all looking at the pre-op bloods. You will do all the pre-op bloods. You will do all the clerking in. But whether you'll go to theater, that's very, very debatable. Then when you leave a hospital, you cannot give any feedback. So training cannot be improved. You are part of postgraduate. When you graduate, when you go to hospital, you are part of the evaluation of the healthcare system, because the healthcare system relies on you to progress. Okay, you will be the future doctors. So you have to, training is an essential part. You really have to look at your options very, very carefully, where you're going to perform your training. That depends also on different specialties. Not all the specialties are the same in every hospital. And I can tell you that there are specialties that, for example, looking in Europe, there are specific specialized units for, if you want to become a cardiology, if you want to become a respiratory physician, if you want to become a cardiothoracic surgeon. These centers are called centers of excellence. Okay? And centers of excellence are very important, because these are the ones that will give you the training options, the best training options, because they're very, very structured. They do have their own sort of paths in assessing the training they provide to you. Not like, going to a smaller hospital is not going to give you experience, but you really need to understand that somebody is going to be responsible for you. You will have an educational supervisor. This educational supervisor will look after you through the paths of becoming more and more and more experienced as a doctor. And this educational supervisor will also assess you during the training, exactly as we do. You have your logbooks, I suppose. Okay, you have your clinical training logbooks, and you do get some, some evaluation, some assessment. I must admit, Last year I looked at the logbooks and they were all beyond expectations. So I'm not really sure whether, assessors are actually bothered to give, because it's not about giving you a mark above expectation. It's about being objective and for you to correct any sort of shortfalls you have in training. That's the whole point of having a logbook. It's not about saying that we have the best students in the world. That's not going to make you a better doctor. Okay. Same thing about yourselves for those who train you. They won't train you very well, and they won't train your colleagues very well. If you say back to them because you're scared that if I put a lower grade, this person is not going to actually allow me to work forever. And that has happened in the past. But the thing is, other doctors will come after you, and they need to be trained as well. Okay, so you have to be very, very objective, both yourselves, but also the assessor. Okay, I can tell you that in the UK, for example, when you go through training, after you graduate from medical school, there are specific stages every year that you have a very formal assessment. Okay, and this assessment is done by a completely separate organization that is called Health Education England. So this is completely separate from the hospitals. Okay, so this is because this is an independent organization that can actually put the pressure to the hospitals to train doctors better. Okay, because if you allow the hospital to take over the training, they would not recognize any shortfalls in training. So that's why you need an independent organization. Everything has to be assessed in order to progress properly. So certainly you do have options, and one of the greatest things that you have studying at EUC is the fact that you actually study in English, okay? And that can open you many doors, right? So that's very, very important, I think. However, some people would say when they start, and we've seen that the medical career is not my cup of coffee. So it might actually turn out to be something that they will need to follow a different career path. So other options include working in the pharmaceutical sector as a doctor. Okay, there are many people who actually go for jobs like medical science liaisons, okay, or medical directors in big pharma companies. Okay, and they don't want to be very heavily involved with the clinical setting. Okay, that's another option. It's not something that you can ignore. Okay, but this usually starts after you do a couple of years within medicine. You start your career, and then you find that, well, actually, patient contact is not, my favorite thing, or actually there's too much stress because, as I told you, the healthcare systems are becoming more and more demanding, and you will find that quite often people can be quite stressed about, going through this day-to-day job. That's why, the skill mix of the staff is very important. When you work in the healthcare sector, it's not only the doctors, it's also what else you have along with yourselves. I mean, you have nurses, and the nurses, the beauty in England was the nurses had different roles. It wasn't that you go on the ward and you find some nurses looking after your patients. There were specialized nurses. For example, if you were a gastroenterologist, you could have a Crohn's nurse. Okay? In hematology, you can have the leukemia nurse. Okay? In oncology, you can have the lung CA nurse. Okay? So there are the so-called specialized nurses. And then you had another body called the advanced care practitioners that were developed through nurses as well. So in our case, in our department in hematology, the advanced care practitioners were doing all the bone marrows. They were putting all the central lines. They were doing all the lumbar punctures. There are countries where you will see that these procedures are only done by medics. However, by having these nurses doing these procedures, you actually gain so much medical time because we don't have enough medics. I mean, if you look around the world, there are not many doctors for the population we have. Okay? So you have to try and buy time as well. It's not only like you work tirelessly as a medic. You need to actually collaborate with other sort of healthcare professionals, and they're very important. Pharmacists were also very important. Okay, so you do a ward round, and you had your pharmacists with you, and they can regulate some of the drugs. I mean, for example, we had patients who had the bone marrow transplant, and they were actually having antiemetics. They didn't feel sick, so the pharmacist would say, well, I have no sickness. the patient has no sickness. Why don't we stop the drugs? Okay, so everyone can contribute, and this way you can get a lot of the work fatigue from yourself. So, you know, places where they have established teams are very, very important for your future career, because it will give you the time to learn the things that you need to learn as a doctor. My experience when I first graduated from medical school, when I started this rural service in Greece, was, well, actually, you have to go and measure the blood pressure of the patient, measure the, how much urine they passed, what's the heart rate, what's the weight. Do you think that this is a good use of a doctor's time? It isn't. Because you need the doctors to make complex decisions. Okay? You need to help in other ways. In other countries, you have something called the healthcare assistants who are doing these things, not even nurses who are actually doing the observations. So that's why, to structure the system and to be part of the system is very important, but also to be part of a system that will give you the time to evolve yourselves, to train yourselves, and become good professionals. Okay? So that's very, very important when you look for your next job. Okay. As I said before, if you think that, if you don't like your job, sometimes there might be fatigue from the job, there might be fatigue from university going straight to a job. There are times when people do take some time off. Okay, they can take like 6 months off, for example, when they can do other things. They can do research. And this is something that people do like to do, and they never come back to the medical career. So they do become medics, but they're mostly based in a lab. Okay? And that's very important as well, because you really need to have all the things that we implement in medicine, they do come through research. They don't come on their own. We don't wake up one morning and say, well, we'll give you this drug, because that's actually drugs that have been used in clinical trials. They've been used extensively in lots of patients, phase 3 clinical trials with lots of patients. And it is something that people do use their medical time to. As I say, patient contact is not for all of us, okay? You either have it and you continue with it, or you don't. The next thing, which is linked to the research, is also the academic positions, and whether you want to become an academic in one of the universities, and how much patient contact you have. That's also regulated. I mean, for example, here at EUC, you have noticed that there are different people you see here and different people you see in the clinics. Very rarely you see the people who teach you here to be in clinics. Obviously this will be improved because it is a young university and we're looking into incorporating both the academic and the clinical together. But for the time being, you can see that there are two different jobs, okay? And you can still do one job and you don't have to do like the patient contact. So there are options after you graduate from medical school. But the thing is what you really want, and sometimes even if you don't know which direction you're going to follow, it will be good to go through your first years of training, the junior doctor training, and then after that you can actually decide whether this is what you actually want. It's completely different, as I say, being in the university. It's completely different being in the real healthcare setting. But the medical profession has opened lots and lots of doors, okay, and this has actually made this profession even more appealing. Another thing which, however, it does require some of the medical training to be performed, and usually it's a bit more senior in the careers, is the medical management. So I've done an MBA, okay, so I've done my medical training, I've done my PhD, then I've done an MBA in health management. And that's how we manage things in the UK. So I got a management role along with my clinical role. And if I didn't like my clinical role, I could have stayed just in the management. That's, again, up to yourselves what you want to do. But in order to perform your managerial duties, you need to have some background on how you can actually manage people, how you can manage healthcare. But at the same time, you need to know, by observing, at least for some time, how things work within a hospital. So certainly there are plenty of opportunities. And once you graduate, you will definitely consider your options. My advice is, if you go for the clinical training, to find the best place where you will do your clinical training, the place where you will have both the opportunity to see lots of patients, to take responsibility for your patients, but also to be assessed when you take responsibility of your patients, and to assess your trainers as well. This is like a healthy environment, and where you have multidisciplinary teams. Okay? This is where you have the full capacity of getting the best training. If you don't go down that route, and there are the other routes, again, you always have to think, even if you don't see patients day to day, you still have the responsibility of the patients. You're still, looking after patients in different ways. And the patients are going to be the center of your focus. For example, you might be in a pharmaceutical company, and you might be responsible for clinical trials. You can see that there are, as I said, all the differences, all the changes in medicine have been done through clinical trials. And this is very important. It's very difficult to do things without having the so-called evidence-based medicine. Okay? And then finally, as we said, the other options about medical management or academic career or research. We have seen how quickly research is progressing within COVID-19. There have been so many changes. There's been so many lab-based medicine, and certainly things have progressed even in the context of clinical trials so quickly that if you look at the clinical trials about 10 years ago, they were roughly about 20 to 25 times slower in adapting clinical trials and adapting new practices. So I think that's what I want to say for your postgraduate career. I'm sure that you're all committed to medicine in different ways, and you will all find the ways. From my perspective, what I have to tell you is that whatever you do, you need to really like what you do. If you don't like what you do, it won't come on its own, okay? And think about you're dealing with lives. You have to be committed to your training, whatever this training involves, and then you have to be committed to your professional life. If you think that this is something that does not really fit your career, then you will need to find an alternative route. Okay, don't try to stretch it too much, because first of all, it will damage your own mentality, and then your patients. So I'll be happy to take questions. I think, how many of you are preclinical years? Are you? So you have 3, okay. And the rest of you are clinical years?
Yes.
Okay, towards the end of your career, okay.
One thing I think that many of us really did not understand is what exactly is a fellowship, and what exactly do you do there?
Okay, so a fellowship is something a little bit later in your career, okay. So once you think about what you want to do, okay, let's say that, we said earlier you want to become an oncologist, okay? Then, as an oncologist, you might have a fellowship in breast cancer. Okay, so the fellowship is a sub-specialization. Okay, so you do have a period of time where you train in a particular area of your specialty. So fellowships are usually enhancing the knowledge. It's more specialized knowledge within the actual specialty. And fellowships are very trendy, because obviously you can see how specialized medicine has become. I've done my fellowship in bone marrow transplants. Okay, so it was an area of hematology. Okay, I wasn't doing hemophilia, but I was doing bone marrow transplants. And that's because the knowledge has become, especially now with the molecular studies, like going down to the very, very, neat roots of pathophysiology, neat roots of, disease formation, that it's very important to know what you're doing. It doesn't mean that you have to lose your knowledge from the other specialty, because quite often you'll find yourself exposed to that. And it also depends on where you want to work. We mentioned earlier about centers of excellence. Usually centers of excellence work in a very over-specialized routes, okay? So you are in a center of excellence, let's say that You are like the cardiothoracic surgeon and you do only like heart valves, okay? Or you might become like a respiratory medicine and you do specialized in asthma, okay? So there are lots of things that you can do. Some people, for example, if we think about the UK, there were the district general hospitals and there were the university hospitals. District general hospitals, it was very difficult to see specialized units, unless it was a big area, big catchment population. Let's say in hematology, thalassemia. Okay, thalassemia, you might have a place where you have a lot of patients with thalassemia because in the UK there were lots of Asian populations that had thalassemia, lots of African populations that had sickle cells. Okay, but again, these were better managed in big centers of excellence. Why? Because sickle cell patients do not only have a hematological disorder. They can have cardiac problems, they can have endocrine problems, okay? They can have psychological problems, obs and gynae problems, okay? Cardiological, renal problems. So you really need a place where you will have adequate support for these complex patients. Because usually they have more than one abnormality. So in a DGH, it will be a bit difficult to find this specialization if you have a district general hospital. So that's where, and fellowships usually are given, as I said, in places where they do have this knowledge, specialized knowledge. Usually it's done after you finish your specialty, not during the specialty. Orthopedics, you can see, like, you can have, hip replacement fellowship, or a knee replacement fellowship, or like knee fellowships. So there are areas within the specialty that they focus on, and that's usually done after specialization. Thank you. Any other questions? Yes? So first of all, you need to think what specialty you want to do as a broader sense. So do you want to do like a medical specialty or do you want to do a surgical specialty? Okay? Because I will give you the idea which way you're going. In any case, so for example, depends on the country that you go. So if we think about the UK system, you do something called the foundation years. Okay? So the foundation years give you and that's why it's called foundation. It gives you the foundation to progress with your career. But then, while you're doing these foundation years and you do sit for an exam, you have the opportunity to think what you want to do next. And because of what I mentioned to you about health education in England, there are different deaneries. And you will hear which deaneries are actually giving you the best training options. Okay, and it all depends on exams because you have constant assessments as well. So this will give you the route to where you are going to go next. Okay, and while you're applying, you have 2 or 3 choices. There was 3 choices before. I'm not sure now whether they have changed it. And depending on how you're actually doing on an interview, then how well you have done on the interview, you can go through your first choice, second choice, or third choice. Okay? But during this time, when you are at the early stages of your career, you want to actually see which specialty you're going to do and which is the best place to do this specialty. And there are different ratings. What you will see, there are data in health education in England that depending on the deanery, you can compare training, how the trainees actually rate. And that's why benchmarking is very important as well in training, when you become doctors. And that's why it's important for you to rate, the hospitals, to rate the people who train you, because this is the way for others, both for others to improve, other hospitals to improve, but also for you to make an informed choice. Okay? Without having the data, you cannot do an informed choice. Don't forget, when you give a treatment to your patients, there's something called informed consent. This informed consent is actually done because you give the information to the patient. Okay? Who's planning to do training outside of Greece or Cyprus? Wow, okay. Okay. So do you have anything in mind where you'll actually...
For me, it's Germany. I'm thinking the UK, so.
Yeah. So usually in Europe, UK, Germany, France, Israel have very good sort of training options. Okay. Switzerland is a bit more difficult to go. But these four countries, they're the ones that both there's a lot of demand for doctors, but also they are good, they are known for good training provision. Don't expect that everything's going to be perfect, and that's where your role is, to try and improve things. Because no matter how junior you are, you can still make a difference. Okay? We've seen, I'm not sure whether you've read things in the UK about the junior doctor strike recently. Junior doctors have been so much undervalued for a time, and they were going through all the right processes to try and improve things. Because when I went to the UK in 2003, and when I left in 2021, the salary of a junior doctor was more or less the same. And you can imagine how much the cost of life has changed. Okay, so there are things that governments need to pay attention to, but that's all done through the bodies of, the medical bodies or any other professional bodies that they do push for a change. And certainly, things will not always be, you can think that the grass is always greener on the other side, but it's not like this. You have to try hard to achieve what you want in your training. Thank you very much. Thank you.
Thank you so much, Professor Nikoloussis, for this lovely introduction into the different residency options that we have as medical students. With that said, I will now give the floor to Dr. Roman Pax, the director of EUC Medical School in Germany. Ne.
Hello. Hello, everybody. Here we are. I hope you can hear me well.
Yes, we can hear you.
This is super. So, welcome to the Q&A session about having your internship in Germany, about having your further on qualification in Germany. Let me just introduce myself with a few sentences. My name is Roman Pax. I'm actually the director of the EUC company branch in Frankfurt, Germany. I'm basically a specialized forensic medical expert. I've been working at the public university in Frankfurt for 15 years, at University of Heidelberg for 10 years, and I joined Galileo Global Education 3 years ago. Furthermore, I hold an MBA in international management. So I think I can both share with you the perspective of the public universities, also the private universities, and also I've been active in teaching young doctors for more than 20 years now. So I'm more than happy to discuss with you the options you have when you make up your mind coming over to Germany, how you can specialize, how long it goes, salary, and so on. So please ask me.
Any questions for Dr. Roman Pax regarding salary in Germany or internship programs?
Hi, thanks for joining us. My name is Paul, I'm German also, and I have one question. How can we differentiate us coming from a private university compared to all the students coming from public universities in Germany. I often hear that chiefs asking for students not from private universities, rather from public universities, as they know what they're getting. Let's say a student from University of Heidelberg compared to one of us. How can we make sure that this difference is not there, or how can we, show them that we're equally as good?
First of all, to be fully open, please have in mind that you are in fact better educated than students from public universities in Germany. This is for sure. The quality of your program is indeed higher. So it's a bit of a traditional thing. Perhaps you made the experience by yourself. You often think that experience you made yourself are good experiences, and that the way you have taken is perhaps the best way to do it. And people are often a bit shy if someone has another approach, has taken another route to the goal, has other experiences. But basically, I can assure you, you are better educated than the average student from a public university in Germany. This is for sure. And of course, as there is in Germany, there is such an immense need of doctors. Times when it was, oh, let us choose between this one and this one. Well, he has this, the other has that. These times are gone. If you have good marks are of course helpful. But the rest is up to you. It's up to you how you present yourself in the interview, how friendly you are, how communicative you are, and at the end of the day, it's a sales process. At the end of the day, it's up to you how good you sell yourself in this very moment.
Another question.
You need not be shy. Absolutely not. Please be aware of the quality of your education.
We have another question.
Hello, doctor. My question is, what's the difference between working in a big university hospital to working in a small hospital in a small city?
Well, first of all, there are also big hospitals in Germany which do not belong to a university. So the actual differentiation is not between big university and small in any other city. In Germany, hospitals are graded in different levels, from primary care up to maximum care. And actually, all university hospitals are hospitals of maximum care, but there are also non-university hospitals which are also hospitals of maximum care. This just to enhance your understanding. Main difference between working in a university hospital and a non-university hospital is that in a university hospital, they will more or less strongly expect you to do research. Yes, if you work at university, especially if you work in a university of a higher rank, like University of Heidelberg, where I worked the last decade, you are expected to contribute to the scientific output of the university. Meaning, you do your work on the patient, whatever subject you do, plus you do training. You train students, of course, give lectures, seminars, and so. And the third thing is you have to contribute to research. And the research is at the end of the day, when it comes to offering you another contract, prolonging your contract, your research output is the essential thing. If you work at a non-university hospital, you just have the task of teaching of teaching patients, basically. This means you are not obliged to do the other thing in parallel, which is often very, very time consuming. So at a non-university hospital, it's actually, they will be content with you if you are just a good doctor, if you do a good job in treating patients. And of course, you improve your own standards, gain additional knowledge or so, but they do normally not expect you to do research. This is the main difference.
Thank you. Another question.
Hello, I wanted to ask in general, what are the basic prerequisites required in Germany for us to do our specialty? What, I mean, the German state and the hospitals ask from us to go to Germany and do our specialty?
Well, this is actually the same, pretty much the same as in any other European country. Of course, you need, first of all, you need your graduation from UC in Nicosia, of course. And with that, you will get your license to practice medicine in Cyprus. And you are quite aware of the fact that this also means, due to the Bologna process, that you also can apply for a license in any other European country, in this case in Germany. So you can, of course, apply for the license in Germany, but in addition to your graduation, in addition to your diploma, you need to prove good German skills. It's actually B2 level in general German and C1 level in medical German. By the way, this is absolutely the same if you want to go to Italy, to Spain, to any other European country. You always need the local language in general at B2 level and C1 at medical level, in the medical field. All right. Furthermore, in Germany, you need a certificate from a doctor, which is more or less easy to get, that you do not suffer from any serious disease, and that's it. Yeah.
I think Dr. Bugs got us covered on that question. I have also a question. Since we don't have an EUC graduate currently doing internship residency in Switzerland, is the application procedure the same like in Germany?
No, in Switzerland it's actually different and very important. Switzerland is composed of, you could say, of counties also that are called cantone. And from county to county, rules can be very different.
Okay, thank you. Yes, we have a question right there.
Hi. What is the importance of the Doktorarbeit in Germany? Do we need one? Because it's... No? Okay.
No. Actually, guys, when I did my medical studies 100 years ago, I graduated in '93. Actually, at that time, it was more or less expected of a medical doctor to hold a doctorate. So most of us did this. Today in Germany, 60% of all doctors who are active in a hospital and healthcare center or have their own office do not hold a doctorate or a PhD. If you want to go for a scientific career at university, you will at one point in time need your doctorate or your PhD for being able to do the next steps, habilitation, becoming a professor, and so on. At a public German university, you cannot become a professor. You cannot even get the habilitation if you don't have, or if you don't hold a doctorate.
Thank you. And now another question.
I would like to ask about taxes. I would like to.
Would you like? No. One time and it works.
I would like to talk about ask about taxes in Germany, especially for doctors or general.
Well, For this, you should know that each third paragraph on taxes on the world is actually a German paragraph. Means, you know, you might know German love complicated regulations. We love this. And when it comes to taxes, it's extremely complicated. So such general taxes for doctors, I could talk to you for 2 weeks. There are no special taxes for doctors. This is pretty clear. Income taxes in Germany are comparatively high. You will know that. Salaries in Germany are much higher than in Cyprus, but also our taxes, especially income taxes. So if you have a special question, I'm happy to answer. But such a general thing, I don't think it doesn't fit into our session this afternoon.
And now we are going in another question.
Hello. I wanted to ask, what are the salary expectations in the first year?
Well, it widely depends if you work in a public hospital. If you work in a public hospital, there will hardly be any room to negotiate your salary. You know, they have fixed contracts which you can more or less accept or not. In this case, when you start as a junior doctor, expect salaries between 60 and 70K per year. If you work in a private hospital, it's up to you how well you negotiate, what you have to offer, how much they need you. You can earn much more.
Okay, thank you. Do we have another question? Yes, we do have.
Hello, doctor. My name is Eleni. I wanted to ask you, I'm interested in pediatric oncology, and I wanted to know if I start from a non-university hospital at the beginning, can I move while I'm doing the oncology to a university one, or during my specialty? Can I move from a hospital to another?
Yeah, you can, of course, always move from one hospital to the other, especially due to the fact that doctors are urgently needed everywhere. If you plan your career, the career path from a non-university hospital to a university hospital is perhaps a bit risky. As I told you already, at a university hospital, they first rank expect you to do science, to do research. If you are at a public hospital, a non-university hospital, you most likely will not have the infrastructure and will not find the time to do research. This means if you apply after, don't know, 3, 4, 5, 6, 7 years at university, they may evaluate you according to your scientific output, and this might not be enough. So this is actually a bit risky. It might work, but if it was my career, I wouldn't plan like that.
Thank you.
Okay, so this is a very specific question, actually. So, how many copies of how many copies of our degree with the apostille do we actually need to get all of everything in Germany done? That we actually get our degree recognized. How many copies? Do you know?
Just one. You actually need one copy, and this copy will anyway have to be translated, and you will need a certified translation by a certified translator. So actually one copy is enough, and then you need, of course, more translations. Fully clear, please have this in mind. If you apply for a job in any country of the world, most likely that you will need all your paperwork, all your documents, all your diplomas translated into the national language. Same for German.
Hello, doctor. I'm a third-year medical student, and I wanted to ask, can we relocate for preclinical years or clinical years during these three, when I go into fourth, fifth year, can I relocate to the university to Frankfurt, or obviously before I graduate?
Theoretically, yes, you could you could relocate to Frankfurt, but please have in mind we started off last October, so we are in our second semester.
But it is possible.
We do not offer a third, a fourth, a fifth semester yet. So actually, if you are in the fifth, sixth semester, you cannot relocate.
So when obviously, okay, logically, when they get to the fifth, sixth semester, I'm probably going to be graduated already. So I understand. Okay, I see. Thank you.
Matter of time.
Thank you. We have again one question from Valerie.
So when we are applying to Germany, can we somehow also get actually help from the European University in Frankfurt with like questions and guidance to like how to like approach this whole process or not?
Yeah, guys, actually, I'm always happy to assist as long as you do not exaggerate. You know, I'm of course my primary responsibility is our campus here, and apart from this, I'm happy to assist as long as it's not exploding. Always give it a try. If it are general questions or so, I will probably be happy to help you. But when it comes to the specific issues with the hospital you are applying to, my options will be more or less limited.
Anybody else? Okay.
Oh, wait. Hi. Sorry, just to reiterate, is it required to have a Cypriot medical license to go to Germany, or can you go to Germany without it?
Yeah, the thing is, the procedure is, you study medicine in any European country. You graduate there, then you get the license in this country, and afterwards you can say, oh, I have a license to practice medicine in one European country, and now I have the right to also apply for a license in any other European country. This is the way.
Thank you so much, Professor Books, for this excellent interactive question and answer session. On that note, we will now proceed to Christos Hadjikyriakos, an EUC medical graduate that is currently in UK for this residency, and will join us live and provide us with his session some quick tips to secure a UK residency. Did I skip here? Yes, they skipped. Hi, Christos, welcome.
Hello.
We can hear you, and you can start with your presentation.
Great, I'll share my screen now.
Thank you.
Okay, hello. So my name is Christos Hadjikyriakos. I graduated from EUC in the summer of 2021. I'm going to be doing a presentation for you all about kind of the pathway that I've taken to currently working in the UK within the NHS and the different options that you have. I'll do a short presentation and then have some time for questions at the end if anyone has any questions. So in order to enter specialty training within the UK, there needs to be some competencies that have to be signed off. Now, this is assuming that you're going to be entering as a medical school graduate, as opposed to having already started a residency program elsewhere. So these competencies are basically, you need to provide evidence that you are at the sufficient level in order to enter specialty training. So that can either be done via completing an official foundation training program, or alternatively, it can be done by having something called a CREST certificate signed off. And I'll go into that a little bit more detail. So the CREST is Certificate of Readiness to Enter Specialty Training. Now, both of these can be achieved either by completing an official program, as I said earlier, or by gaining enough experience either through a trust grade position or a locum position. I appreciate that I'm probably saying a lot of things that don't mean much to you guys right now, but I'll elaborate further. So trust grade basically means that you're locally employed by a hospital or a trust, which is a collection of hospitals, for a set period of time. It's a non-training position, which means, and it's something that I'm currently doing. So it means that although I have an educational supervisor and I have a clinical supervisor, I'm not in an official training program, which has its pros and cons, but I'll come on to that shortly. Now, the F2 standalone is a training post where you enter the official foundation program at the 2nd year mark. Now, the reason this is relevant for you guys at EUC is that the fact that it's a 6-year program, a 6-year MD program, means that you are ineligible to do the 2-year foundation program that the UK graduates are able to do, and some graduates from other countries. So your residency application. As I said previously, it's not possible to advance into specialty training without first completing and proving your competencies. So let's go into these 2 different options with a bit more detail. Trust grade is what I'm currently doing now. So what that means is that my position, I am a trust grade SHO, a senior house officer. So that means that I am a junior doctor who is at a more junior level than a registrar, so someone who's entered specialty training. But I'm still operating, I'm still working as a doctor, as a junior doctor. So these positions are usually advertised on the NHS job website. They are available pretty much all year round, but a lot of them come around August time. That's because that's when it aligns with the regular foundation program. Now, there's something called the Gateway program, which I think TJ, another graduate, is going to speak about in a little bit more detail. Either she already has or she will be. And this is a program that specifically exists for international medical graduates, and I'll come on to that a little bit later. So the alternative option that we have is F2 standalone. Now, the F2 standalone means that you would be coming into the foundation training program at the 2-year mark. Usually in the UK, when UK graduates finish medical school, they go into Foundation 1, and then they go into Foundation 2. So this would involve going into the F2 role. The application for this, for the 2024 application, closes in January. And there's certain things that you need to do in order to apply for the F2 standalone. So it's important, I think, to get the IELTS for GMC registration. Now, there was a little bit, I remember when I was doing this, there was a bit of discrepancy about whether it was necessary, but I thought rather than delay anything, I'll get it done. So it's an exam where you basically prove the standard of English that you have. And that's in order to register with the GMC, which is the General Medical Council. I will also come on to this again a little bit later. The F2 standalone application also involves doing an exam called the SJT exam. This is a situational judgment exam. Usually happens around January time, if I remember correctly. And this is an exam where it's nothing to do with medical knowledge, but it's more to do with how you would react in certain situations. Because European University is within the EEA, that means that there's no need currently to sit the PLAB exam. The PLAB exam is basically an exam, a set of exams that international medical graduates often have to do before being able to come and work in the UK. But it's not necessary for us to do that. As well as this, you would need a letter from the university, which is kind of a letter from the dean, which kind of states that, you know, to confirm that you're studying here, to confirm when you expect to be graduating, that kind of stuff. A draft of this is possible to be found on the foundation program website. Now, the selection program is based on two things, or the selection process even is based on two separate things. It's based on the result of your SJT score and also on your interview performance. The interview is an interview where it will either be face-to-face or remote. They ask you a series of clinical questions. It's normally in front of a panel. They ask a series of clinical questions as well as some questions about yourself and whatnot. It's not the easiest interview, to be completely honest. It can be quite challenging, and you have to have a good standard of medical knowledge in order to advance. So what are the chances of being accepted into F2 standalone? Fairly high, depending on how you perform. It's fairly high, and what I mean in terms of being accepted as well, it's also about whether or not you'd want to take the position that you've been offered. If you're offered, you get to rank locations. So, and then depending on how you've performed, you then get allocated a place, you know, in whatever location. There are certain things you can do to improve your chances of being accepted. So to have, you know, a stronger application. Things that I did is that I made sure I had my ALS course certificate up to date. So that's advanced life support. I made sure I did my ATLS as well. And I sat as many NHS relevant online courses as I could. So that was a lot of these BMJ courses. Another thing as well is any form of NHS experience. I can't stress enough how important it is to try and get NHS experience wherever you can, in the form of internships or anything that you can do to get on your CV that you have NHS experience is really invaluable. We'll come on to this a little bit more again in a moment. So I mentioned something called the GMC earlier. What is the GMC? The GMC is a public body which maintains the official register of medical practitioners within the United Kingdom. To put it into, to cut a long story short, in order to be able to practice medicine in the UK, you have to be a GMC registered doctor. So how do you register? You have to first of all check that you're eligible. Myself and other colleagues who are working in the UK, I guess, are proof that graduating from EUC, you are going to be eligible. So that's one thing. You also need to complete an application. You have to pay a fee, and you have to provide all the required evidence. Now, part of this evidence is providing evidence that your English language is up to standard. That can be done in two ways. Either you can sit the IELTS exam, which is what I did, or you can get a letter which confirms that at least 75% of our course and our clinical rotations occur in English. From what I recall from some of my colleagues, they did the second option, so they got the letter and they were also successful. So it's something that you can kind of find out for yourselves in that regard. As soon as you've finished your final exams, it's important to get a letter from the university confirming the set date of graduation and that you're going to pass all your exams, and then begin the registration. The sooner you're GMC registered, the better. I can't stress that enough. Try and get GMC registered as soon as you possibly can. Now, some details about residency. Your salary really depends on what point in training you are. I'll show you a diagram in a moment, which will kind of show you exactly how, it will show you the exact pay grades. This is also different for locum work. So I mentioned locuming earlier as well, and I'll kind of elaborate on that for you. Locum work is working as a doctor, but you're not working for any specific hospital or any specific trust. You're kind of working, it's kind of like you're working like an agency working doctor. Now, I know individuals that did a whole year of locum work and then they managed to get the CREST certificate signed off, the thing that I mentioned earlier. The reason that it's possible to do that is because in order to get your CREST signed off, you have to have a consultant to sign it who has worked with you for a minimum of 3 months and is confident, and you've proven to them that you're able, that you've got the competencies to have your CREST form signed off. So I know people who have only locumed and then gone into specialty training. It can be done, but it's a route that takes a lot of independence, and it can be quite isolating at times from what I've heard. The good thing about locuming, though, is that your pay is much better than a trust grade or in a training program, because you're paid on an hourly basis, and it's very much so where you're required, you go, so the pay is good. One of the other questions on the presentation that was asked to me was, how are the hours? They're generally quite long. It really depends on what rotation you're on. So the contract that I've signed here as a trust grade SHO is a maximum 48-hour week. Now, that being said, there are situations where I've worked a 60-hour week, but then you have sufficient time off afterwards. So at the moment, my rota, I just last week came off a set of 4 nights in a row. After that, I had 2 days off. And then after that, now I'm currently doing 12-hour days for 3 days in a row, and I'm working the weekend as well. So it is challenging. It takes up a lot of your time, and it is something that you have to that different rotations have different expectations. Specialty training duration can last from a minimum of 3 years. That's if you want to become a GP. Up to a maximum of 7 years. So that's if you'd want to do certain medical specialties and certain surgical specialties. Now, just to make it clear, this is 3 years or 7 years on top of the 2 years of foundation training that most people have to do. The way your specialty training is structured is that you would do a completion of internal medicine training, which is the IMT, that lasts for 3 years. And then following that, you'd have to reapply into specialty training. Just note, this differs for different specialities. There's a lot of different specialities have different requirements. Now, in terms of your own professional development, things that you can do before entering residency training, it's important to undergo many courses. In the UK, they absolutely love it when you can prove your perfect professional and personal development. So this is your courses, online courses, ALS, all of these things. It's all things that can basically make your CV look better, but it does go far. This also includes doing things like audits, paper publications, presentations. All of these things really count towards your CV. As well as this, there are multiple fellowship options, but to be completely honest, it's very difficult to get into a fellowship without first having some form of NHS experience. So I mentioned earlier that there's the pay scales. This is the current pay scales for doctors on the 2016 or the 2022 contract. Just note, these numbers here are for the if you're working a regular week in a hospital that isn't in London. So I'm working in a hospital in London at Northwick Park Hospital. My current monthly wage is around £2,775. That is because I'm paid as an F2. On top of that, I get extra pay because I living in London. There's something called London banding. And on top of that as well, because my rota is currently quite unsociable, lots of nights, lots of on-calls, it means that they increase your pay by a certain percentage as well. So that's kind of how the wages breaks down. Okay, so my pathway. As I said, I graduated in June of 2021 from EUC. I then got my GMC registration done as soon as possible. And I'd already applied in January for an F2 standalone position. I did my SJT, did my interview, and was fortunate enough to be offered a place on the F2 standalone. But I decided not to take it. I was offered a place in a hospital in Salisbury. I decided not to take it for 2 separate reasons. The reason number one is that for personal reasons, I was quite set on trying to get work in London, and I really wanted to live in London. As well as this, I felt that at the time, I didn't have enough confidence in my own abilities to enter into a F2 position. So the assumption is if you're going into F2, you're at the standard that all UK graduates are after having worked for a whole year. Now, I know a colleague of mine who also graduated from EUC. He did the same thing, but he accepted his F2 standalone position. And he said that it was absolutely fine. So it really does depend on your individual view of your own abilities and how flexible you are on location. So after I didn't accept that position, I then applied to this program called the Gateway Program. Now, the Gateway Program is a program specifically set up for international medical graduates, so us. And the idea is that they've created a program which is a foundation equivalency program. It's a 2-year program, which is supposed to kind of run parallel to the official foundation program. And by the end of it, you're supposed to be the same as any UK graduate would be. So I got accepted onto that program, and I worked for 8 months at the Royal National Orthopaedic Hospital in Stanmore. I'd initially signed on to a 2-year contract, but after 8 months at the orthopedic hospital, I felt like what I was to gain out of the program, I'd gained. The reason for that being that being in an orthopedic hospital and not being interested in orthopedics, it meant that I wasn't, necessarily doing work that I felt like was forwarding my own personal development. So I then applied through NHS Jobs, which is a website, for a role, a trust grade position at Norfolk Park Hospital, which is where I am now. Fortunately, I was accepted and I was offered a 1-year contract. So that was in August of 2022. I'm currently just over halfway through that now. So this is a rotational position. I've done rotations in care of the elderly, in acute medicine, and I'm going to come onto my ICU rotation next week. So about your path, the thing that I cannot stress enough is get NHS experience wherever you can. The one benefit I had of doing the 8 months at the Royal National Orthopaedic Hospital is that when it came to applying for the job I've currently got, I had, 8 good months of NHS experience under my belt, so I could prove to them that, I know how the NHS runs, because there's a lot of it is just learning how to function within the NHS. I would say if you're very eager to start working, then being flexible is going to only help you. Being flexible at location, about rotations, all of these things, it's going to really allow you to get your foot in the door and kind of start working as soon as possible. As well as this, I think there is some importance in looking at what rotations you'll do and understanding whether or not that will suit you. The other thing I have to say, definitely with the job I've currently got, the workload is very, very high. The expectations are also very, very high, because as I'm an SHO, that means that I'm working with people who've got, 3 or 4 more years more experience than I do, but you're expected to be at the same level. So you have to learn very quickly, and you have to, be very proactive in learning. So you get immediately put in situations where you're expected to be able to manage acutely unwell patients on night shifts or in the emergency room, in lots of different situations. So there are certain recommendations that I have. Like I said, get NHS experience as soon as you can, whenever you can, in whatever form it comes in. Get GMC registration as soon as possible. I would advise doing the IELTS, but I know it's not mandatory. Do online courses wherever you can. BMJ courses is a very good example of where you can do courses. Get your ALS whenever you can. There are certain websites that are very helpful as well. Savvy IMG is a website that kind of breaks down the pathway for international medical graduates coming and working in the UK. Gateway for Doctors is the program that I first started working with. The BMA has lots of helpful tips on there, lots of helpful resources. And also there's another website called Road to UK, which is also quite helpful. So that kind of concludes the presentation I had. I hope it's been informative, and I'd be happy to take any questions if anyone has any questions at all or anything like that.
Do we have any questions? Yes.
Hello, I wanted to ask, what happens after you finish your contract with the trust you're working on and you go into a specialty? Because as I understood, you're not working in a specialty right now. Like, do you take an exam? What's exactly the process?
Okay, so it's a good question. It depends on what you want to do. So my personal choice, I think I'm deciding what I'm going to do. So I'm going to sit an exam called the MSRA. The MSRA enables me to go into a certain number of specialties. So it's for, there are different specialties require different exams. And it's quite, you know, you have to kind of prepare for what path you want to take. So as I'm thinking about GP training or pediatrics, I'll be doing my MSRA in September. And then depending on the score of my MSRA, I will then get offered a place in specialty training or not. And then you kind of work through that. What you have, and a lot of the colleagues I work with are people who, you know, have applied for specialty training, haven't been successful perhaps, so they still carry on working as an SHO, so the position that I'm in currently, and then you can always reapply, or you can kind of reconsider what steps you want to take.
We do have another question.
Hello, doctor. Thank you for doing this. I'm actually, I've been following actually the news of, especially for junior doctors, and I've heard that there's a lot of strikes going on around this time, and I just want to know, like, what's your opinion about this, and what this, if I want to go to UK, would this affect me or not? Thank you.
Good question. So yeah, at the moment we've striked for 3 days. It was last month, and we've going to do another strike again for 4 days in 2 weeks' time, I think. Now, the reason for the striking is based on pay. To briefly give you the reason we're striking is because the pay of junior doctors has not increased in line with inflation, and we're currently paid 26% less than we were paid at the same time in 2008 in real terms. So in terms of, that's the reason we are striking, and I think it's, you know, my opinion on it is that we ought to be paid more. We are, in terms of, from looking at other countries, especially going through specialty training, you tend to get paid much better. My advice, if anyone that's thinking about coming to the UK, is appreciate the fact that the pay isn't very good compared to the work that you're doing. The work is very intense and is very long. And these are, you know, so it's not easy at any point, is basically what I'm guessing at.
Thank you.
Hi, I have a question. I'm just wondering, how long does it take to actually get GMC registered?
Good question. So let me think. I think I sent off what you want to do is you want to make sure you have everything when you send it off. The worst thing, not the worst thing, but you want to really avoid the GMC having to come back and respond to you saying we need X, Y, and Z because you haven't provided it, because that would delay things. From what I remember, I had I sent off all my documents and was registered with the GMC within, I believe it was within a month and a half of applying to them. So it's it can be quite a quick process.
Following up, in the meantime, during those 1.5 months, what were you doing?
I think for 1 month I stayed in Cyprus and enjoyed myself. I think, you know, after graduating, it's good to take a break and, you know, appreciate that you're maybe not going to live on a place like Cyprus again. I then came to the UK, and then that's when I, you know, was applying for different things and whatnot. I know some people take the opportunity to do internships, and it is good. It is going to be good for your portfolio, good for your CV, but I really would recommend enjoying a bit of time off after graduating before going straight into work, just because once you start working, it's quite exhausting, to say the least.
Have you applied anywhere else apart from UK? Specifically speaking about Ireland, do you know anything about applying to Ireland?
I don't. I only applied in the UK. I do, however, I know one of my colleagues and one of my classmates who I graduated with, TJ Brockman, she's going to be doing a presentation as well, I believe, and then I think from my understanding, she's going to talk about Ireland then.
Thank you, Christos, for joining us online and that you shared your knowledge and wisdom with us. We will now welcome Philip, that is currently a resident in Australia, to share his wisdom with us as well. Welcome, Philip. We can see you and I think hear you.
Awesome, great. So you should be able to see the presentation, all right?
Yes, we do. Did.
Now you should see it, right? Yeah.
Yes, we do.
All right, awesome. All right, guys, so some of you might know me. Some of the older guys especially might know me. I graduated from EUC 2019, and I'm currently placed in Austria at the Unfall- und Krankenhaus in Meidling, which is the trauma hospital in Meidling. And in pretty much starting soon my residency in orthopedics. You sent some questions before concerning Austria, so here I've answered some of them. Let's go. So what do you need to even be considered in Austria is you need to have C1 in German, and then you have to go and do the medical German exam at the Ärztekammer, which is the medical council. If you speak German, if you speak C1 German, the medical exam is not difficult. It literally is you present a case, so they come, they give you a case, and then you just have to present it to another doctor. And then the second part of it is you have to write a letter. It's not difficult. Anyone who speaks German. Then you have to do Basisbildung, which is the basic training. It's 9 months. You either do a 3-month placement, a three-month placement. For my case, it was, because I'm doing orthopedics, it was 3 months of internal medicine, 3 months general surgery, and 3 months orthopedics. You can play around and you can you can go and do the specialties you kind of want to focus on. So if you want to do internal medicine, cardiology, or something like that, they'll give you 3 months of internal medicine, 3 months cardiology, and then 3 months of one of the surgical things, which I know you all love. Or you can do 2, 4, and 5 month placements. That you tend to do more in Vienna because they just want to have you focused and get you out of the way. Be prepared to go in the middle of nowhere. I did my internal medicine in Styria. If you can see my cursor, at that little point, that's where I was for one of my 3 months. So it's in the middle of nowhere. Be prepared to do that. You can do the application with any of the states of Austria. So Austria it's a state. It's United States of Austria. So you can apply anywhere you want to. You don't have to be in Vienna. Doesn't have to be in Vorarlberg. If you ski, Vorarlberg, Tirol, Salzburg is pretty nice. And each of the state, so Bundesland, has its own Ärztekammer, General Medical Council. How is the process of the application? You can do it at any time of the year you want. As long as there's an open place, you can apply for it. The application really depends on which state you are in and where the hospital belongs for example, in Steiermark, Styria, all public hospitals all belong to CAGES, and the application is central. In Vienna, it is literally hospital. So you can have 20 applications going on. You don't need any tests really. For visa, it's an EU country, so all things that are required for an EU country apply here. The documents you need for the applications in general are the Medititel, which means you live in the country, criminal record, the registration, and your diploma. Selection process, it's not very merit-based, let's say. If the professor likes you, you get in. If the professor doesn't like you, that's it. So it's not central, it's not point-based. It's go work at the hospital, you do well, professor likes you, you stay. For foreigners, it tends to be a little more difficult, but if you get in, you get in. So the harder the residency, meaning the surgical residencies are always the hardest ones to get in. Now, one of the non-surgical ones that are difficult is dermatology, and from what I understand is pretty much impossible to get in, especially if you're from outside. If you graduated outside of Austria. So it pretty much is the same everywhere. How can you improve your chances of being accepted? As I said before, be prepared to go outside of the big cities, such as Vienna, Graz, Salzburg, and Linz. Salzburg is like Munich. It is very difficult. The way it is. You can work in the country as long as you're registered with the Ärztekammer. What you can do is go and work at a hospital and work as in research, which is what I did, but you're not really allowed to do any medical work. Salary depends on the state and specialty. Netto, meaning after tax, because they do the taxes for you, the hospital, and they do everything for you. The security, all these things. It's very nice. At Basisausbildung, it ends up being around 1,500 without on calls, and with on calls could go up to 2,000. Then when you're in residency, it can go up to 2,500 without on calls, and the hours, it's residency, it's Basisausbildung, so be prepared to work your way out. So it's 40 hours plus dienst, so plus on calls, and depending on the staffing, your on calls, you could be about 3 to 4 on calls per month. At the last hospital I was at, we were doing 6 to 7 on calls per month. So you live there. Residency, so I know the orthopedic pathway, but I looked up the other ones. General medicine tends to be 9 months of Basisausbildung. Everyone does it. And then you go to do turnus for 27 months. So you go from hospital to hospital. And then you do training, and then you do your exams. Then for other specialties, such as, let's say, cardiology, you have to do the 9 months, as we said, basic training. And then it's 36 months of general training, let's say internal medicine, and then 27 months of your cardiology. Don't quote me on that because I'm not 100% sure, because that's not my specialty, so I don't really know about it. But you can go on the Ärztekammer website and they have it. Orthopedics, which we all love, is 9 months of basic Basisausbildung, and then you go straight into ortho and trauma. 32 months of ortho, 32 months of trauma, and then 8 months of hand sports. the structure is, it varies really from hospital to hospital. You could be in a very good hospital like let's say Graz, at the University Hospital of Graz, and they have the logbook. You will go into surgery 2 times a week maybe, and you are not really there to hold, and you're there for the on-calls the whole time. Development, you definitely go to workshop, you go to conferences, especially if you're in a university hospital, they make you go these things. Choosing Austria, it's a German-speaking country, and it is really a stepping stone for Switzerland and Germany. The Graz works really well with Zurich, Switzerland, Vienna, some of the hospitals work really well with Swiss hospitals. The hospital I'm at works decently well with Heidelberg. A lot of Austrians do end up going to Germany to work. So it can be used as a stepping stone. As said, be prepared to go outside of the big cities. Don't expect to be in Vienna, going around Stephansplatz and having coffee every day. You could end up in Neustadt. You could end up in small cities, small towns. You could go up in the mountains in Villach. It sounds nice. You could be going skiing, but you're really there to work. Language. For my German-speaking people over there, especially my Germans, Austrian is Austrian. There are so many dialects here. Even Austrians don't understand Austrians at times, so be prepared with that. So if you go to do your training, let's say in Vorarlberg, go to your Basisbildung in Vorarlberg, because it will give you those 9 months, will help you a lot with the accent. Vienna has its own accent. The support that you receive depends on the state. Again, Starmax is really good. Vienna is just chaos. It's a big city. It's the capital. You have the university hospital. At the university hospital, you've got all these professors that are fighting each other. It could be that you got really good setup, or it could be that you're fighting yourself. Getting in easier. Do your Basisbildung in the state you want to work in. Do that, because when you get there, you're going to start talking with these people you're going to be working with for the next 6 years, 5-6 years. So start getting that relationship, and then that means possibly that your professor's going to like you, or he's going to say, I can use him, because over here it really is use and abuse. If I can use you, I'll use you. Do extra placements at the hospital you're working in, like go and do research while you're waiting to do your language, for example. And you really have to network. You really have to speak with people, because here it's not like in the US where you match, where you have the USMLEs or all these exams, and you just match. Over here, they do not like you, you're not getting. Or if no one knows you, you're not getting. They really have to be short-staffed. And be prepared to do long hours. I can speak from my half, is you are the foreigner, and you are expected to do more hours than the Austrian. And research, depending on where you go, can help. Can help, and in some places it's just, I'm here for you to do surgery. I don't care that you've done research. But in some places it can help you get an extra place. Any questions? Yeah.
we have any questions for Austria? We do have one question.
Hello, I just wanted to ask, what drew you to Austria instead of, like, let's say, Germany, or try to getting into Switzerland? Since, I don't know.
I went to school here. So before I came to Cyprus, I was in Austria. I've lived in Austria since 2006. So I speak Viennese. If you ask the Germans, that the older generation at your university, they'll tell you I speak. So that's why.
Okay. Any other questions? No. Thank you, Philip, for joining us. Now we will welcome Eliana Struthu on the floor, representing Doctors of the World, to deliver her workshop.
Hi guys, so my name is Eliana Struthu. I'm currently a psychiatry resident in a military hospital in Athens. However, I will not be talking about that. If you have any questions regarding that, we can talk about it in the end. Today I'm going to focus on humanitarian medicine, which is what I've been doing since my graduation and until last month. I've been working in the field with international NGOs, and I'm going to start with Doctors Without Borders, which has been my most recent mission in Greece, and up until now it has been also my favorite NGO. So I'm going to start with a quick video. Hopefully that's going to work.
Stop bombing hospitals, stop bombing health workers, stop bombing patients.
So, I'm going to talk a bit about who MSF are, because there's usually loads of misconceptions regarding that. We're not just doctors, nurses, midwives, and pharmacists. So the network consists of engineers, drivers, cleaners, psychologists, logistic support. We have projects in over 70 countries, so as you can imagine, that requires a lot of support. It doesn't mean just war zones and tents and sea and the air. A lot of our workforce is in offices. As you can see from the map, there are quite a few projects in Europe as well. So what do? MSF action is based primarily on medical needs. We do not care about race, gender, religion, or politics, but that also means we do not really interfere with them. We go where others will not, either because they are not allowed to, they are too afraid to do so because it's risky or they cannot afford it, but we go there because there is a medical need that cannot be covered. A main pillar of the MSF activities is what we call advocacy in the humanitarian world, which means speaking out against what we see. And what separates MSF from other NGOs is that they're allowed to do that because they're very much independent. They do not rely on states for funding. They rely on people like you and me, €5 per month, and that allows them to work in projects in over 70 countries in the world. I like to describe MSF as more than a humanitarian NGO because they do not only provide medical care. They go beyond medical care. They do lobbying for accessible medication worldwide. They do a lot of research. For example, on drug-resistant TB now, there's been a drug that's released, or malnutrition. They do a lot of advocacy, as I've mentioned, and of course, they focus a lot on education, and not just educating their staff, also educating their communities and their beneficiaries. Of course, all of that is done in the scope of equality and justice worldwide. On the left, you can see on the top one of our airplanes from the mission in Congo, and below, one of the missions I find the coolest, actually, is in Ukraine. After the Russian invasion, MSF took a train, a regular train, and turned it into an ambulance. So they take people that are wounded from the war zones and transport them into the mainland to be treated in Ukrainian hospitals. So this is very characteristic of what MSF do. They go where others won't in emergency situations and intervene in very creative ways. Now, a bit about how it works. There are two main pathways. The first and the major pathway is the national, which is how I applied and how I joined MSF, and then the expatriate staff. They very rarely accept medical volunteers, so if you're looking to volunteer, this is really not the option for you. National staff, like me, for example, I'm Greek, I applied for a project on Lesbos Island in Greece. National staff apply to each country's job listings through the website. So, for example, I went on MSF Greece, so there was a job listing for a doctor on Lesbos, and like any other regular job, I just applied and sent my papers through that. Now, if you want to go to another country, for example, someone from Cyprus or a German wants to go to the project on Lesbos or the project in Congo, for example, you have to apply to your own country's MSF pool. That means you put all your papers for your application and you join a candidate pool, and then you have an interview and you go through a process which we call matching, and they match you with a project that's more close to your expectations, to your qualifications, and of course your interests. Now, usually, I would say the vast majority of MSF projects are very low resource settings, so do not expect the standards you're used to up until now. And you can go from 3 months. For example, now in Turkey, after the earthquake, half of our staff were actually proposed to go for 3 months as an emergency mission. And of course, if you like it and there is the option, you can stay for up to 2 years. Of course, office jobs are much more comfortable, and people may choose to stay there also with their family. Now, it can be quite flexible. It's a misconception that you have to do that forever. You can go in a single mission and never do a mission again. You can go in between gaps in your specialty, or you can do that for life. There are people that do that for life. That's their job. Now, there are also location options. For example, you can choose not to go in a war zone. You will not be forced to go to a specific project. They give you options, and you might be matched with more than 3 or 4, and you get to choose. Again, pictures from Congo and the project in Ukraine. Now, how do you become part of it? Of course, again, with the two different pathways, there are different criteria. So for the nationals, it depends on the position, really. If you're applying for a low-level medical position like I did, I applied after a year following my graduation, the criteria are not that difficult. They need a license to practice. Of course, you need to speak the local language. Usually, you require experience. For example, I worked in a migration project, which means we dealt with refugees and asylum seekers, so they required of me voluntary or previous work experience with that group of people. Usually, unless you're in sub-Saharan Africa, the national pathway is very competitive because, for example, in Europe, the projects are small and do not require many doctors. So you need to have a strong application, you need to have volunteer experience, and you need some sort of learning focusing on the group that you will be treating. Now, for the expats, they require a minimum of 2 years experience, and of course, they really like tropical medicine subspecialty. If you've done any courses, any masters, they will choose you based on that. Languages are super important for MSF. I cannot stress this enough. They love French, but they absolutely love Arabic. If you can speak both of these languages, you get placed immediately in pretty much any project with MSF. Now, the one thing that's common with other NGOs also is NGO experience, which sounds a bit silly because in order to get to an NGO, you need NGO experience, but then how do you get the NGO experience? But this is something they all ask for. Now, unfortunately, there is no MSF Cyprus, but it does exist in most EU countries. So if you're interested, you can just go to the international MSF website and just type your country and you will be directed. If you're from Cyprus, it's best to apply through the Greek website. Now, some things that you need actually to have in order to apply: flexibility. And flexibility takes a whole new form when we're talking about MSF. For example, On the left, you can see pictures from our search and rescue missions in the central Mediterranean. These people on this mission can live up to months in big ships. So if you're a doctor there, you do not only do medical work. You scrub the deck, you also clean the toilets, you're on rotation. So do not expect to be treated like a doctor in a hospital here. You need to be neutral, even when sometimes it doesn't feel right to be neutral. If that's what the administration tells you and what the management tells you, you need to be neutral, because MSF works in conflicts, and the reason why they're allowed to work there is because they are neutral. Now, finally, you need to generally have common views and ethics with MSF as an organization to an extent. Also, emotional resilience, and I cannot stress this enough. Most of the projects are very demanding emotionally. You're in touch with death a lot, you're in touch with a lot of trauma, which is a big risk factor for burnout. Also, the working hours are absolutely terrible. So you need to be able to withstand that. And of course, ability to work under pressure in challenging conditions. That's something we all say in medicine, I think. Like, to enter med school, you need to work under pressure. To enter surgery, you need to work under pressure. So it's something that we say a lot. But again, this takes a whole new meaning when we're talking about MSF, because imagine doing a surgery in a war zone where bombs are being dropped right next to you, or when you're being targeted by militia groups. It is actually a lot of pressure and a lot of responsibility. Now, I want to talk to you a bit about the project I worked on, because it's something I have very, very close to my heart, and I also think it's quite representative of the work MSF does. If you're Greek-speaking and you're interested in applying, you are most likely going to join that project at some point. So the project was separated in two main parts. The first part was medical and psychosocial support provision for highly vulnerable people. That means refugees, asylum seekers, and migrants. And highly vulnerable was sexual violence survivors, torture survivors, and severe psychiatric cases. That was quite intense. We had a clinic where we provided support for these people. But the most interesting part of the project for myself was what we called emergency medical aid. So that was a part of the project where we provided emergency aid following asylum seekers' arrival on the islands. I was on Lesbos, but we have a similar project on Samos. So what that practically meant was a boat of asylum seekers is landing on the island. Those people try to hide so that they're not illegally and forcefully returned. And then we're the first person that reach the spot and try to find them and treat any injuries they have. That meant we were frequently in touch with shipwrecks, death, also live births. We had to do CPR. So you're in touch with very, very basic medicine, but also a lot of the mental health impacts. Now, a lot of our beneficiaries reported violent border practices, such as the violent forced returns to Turkey from Greece, and they said this was done by the Greek authorities. Now, people arriving need urgent care, as I said, not just for births, not just when there is a shipwreck. They're frequently in severe distress due to their journey. It's a very demanding journey, and you need to understand that sometimes these people that go in a dinghy, in a small boat, they don't even know how to swim. Now, what we did was a lot of advocacy about the severe consequences of border violence on people's health and also the politics on migration. But what's important for me and what's important for you to understand is that, for example, we might disagree on the politics of migration. We might disagree on the ways the refugees arrive to our shores. However, what we cannot disagree on is that these people need urgent medical assistance. No one else in Greece is providing that. All the NGOs have been criminalized that we're doing that, so MSF is the only one that's doing it. And that's why we're there, not because we disagree with Europe's politics, but because these people need urgent medical assistance. These are pictures from our project. This is very common that we find a scene like this. Now a bit about my pathway and how I ended up working for MSF. If you noticed, I said earlier that you usually need 2 years. I had not completed 2 years of experience when I joined them. So I started with having a lot of volunteer activities from high school, but also throughout med school. I was part of the group of people that funded EUCMSS. I was also volunteering for the CAMeSM back in the day. It's very important that you guys stay active with your communities and also with other in the humanitarian domain if you want to approach it. It's also very important to have continuous learning. There are courses on EDX, Coursera. I would also recommend the IOM, which is the International Organization of Migration, and Tembo, which is an MSF platform. Free courses, and you can sign up and do it at your own pace. They all have a certificate, and it's actually really important knowledge. If you want to get into the humanitarian domain, you should actually take a look. Then I graduated. It's really important that you graduate if you want to actually participate in those NGOs. The one thing they have in common is that they require license to practice. Even if you're just volunteering, they usually do not accept medical students. So really focus on getting your degree on time. Now, what I did right after graduating, I went to the first NGO that accepted me, which was Doctors of the World, which we call MDM. And I went in their polyclinic in Athens. I volunteered there for a bit, and after a while, they offered me to go as a volunteer again on Lesbos Island, because I'm actually from the island. My mother is from there. It was easier for me to go, and I immediately accepted. I then volunteered in the refugee camp that is on the island, which is actually pretty hardcore. There is 1,500 people. There's only one doctor. There were times that I had to do night shifts and I was the only doctor. But of course, this gives you a lot of experience. I then got an actual job there because at first I started as a volunteer, then I was offered a job. I left that job to go volunteer again in the Ukrainian border with Doctors of the World. That was a very interesting experience. I then left that because I was offered the job with MSF, Doctors Without Borders. That had been my dream job before I even started medicine. So that was my end goal. All my volunteer activity and all my work activity was in order to be able to apply for that job. And because I had experience on Lesbos with refugees, they accepted me even though I did not complete 2 years of work experience. Now I just left that job so I can finish with my specialty because I want to go back to MSF as a specialist psychiatrist. On top of that, I'm doing a master's, which is on global health and disaster medicine. As you can see, it's not on psychiatry, but again, it's close to the humanitarian domain, so there is another way I can approach that. An example for you guys that are not Greek or not Greek speakers, and for example, Doctors of the World, MDM is not accessible to you, is Red Cross. Red Cross usually accepts volunteers, even without a lot of experience, and you can find Red Cross in most countries. So the tents, this is a picture from the refugee camp on Lesbos when I first started working there. 1,500 people, not ideal. And on the right is one of our consultation rooms. Again, pretty different compared to what I was used to here. But as I said, little resources and you have to do very basic medicine. These are pictures from the Pope's visit, late 21. That was also a very interesting encounter. So, to conclude, if you want to go into humanitarian medicine, it's a very, very rewarding path. It combines unique experiences that you're not likely to get in your home country. And of course, it also combines traveling and meeting people with different cultural backgrounds. It's very, very interesting, but it's definitely not for everyone. As I said, it requires flexibility, it requires emotional resilience, and of course, it requires time that is not in your specialty. I would highly recommend to work nationally, volunteer with NGOs in your country, volunteer with NGOs or work with NGOs in a country similar to yours before going on a mission abroad to avoid the cultural shock. And of course, never stop learning, not just in order to get to that pathway, but throughout it. There's not such a thing as too much knowledge, I think. So on the left, you can see Oni. He's one of the mental health support dogs from the project in Mexico. As I said, very, very broad team. So this is it. Any questions?
Firstly, I would like to thank you for coming here to CAMeSM physically. And I have a question. You said that you're doing your master's degree. Have you started your master's as soon as you graduated from EUC, or is it like more recently?
So I could have started immediately upon graduating, but I skipped the deadline. So I started my master when I joined MSF, because at the time I thought I just had signed a contract that said 5 days, 8 hours, so I thought that would be manageable. I was doing my master's online. Of course, after signing, they told me that it would be 24/7, so it became a little bit more challenging. But of course, yeah, that's in the past now. You can start your master's immediately upon graduating.
And what was the duration of that? Was it 1 year, or are you still on it?
The master's?
Yes.
The master's, for anyone interested also, it's offered by University of Athens. It's primarily in Greek. The duration is 2 years. You can do it online, but the second year is much more relaxed. It's once per week. And the last semester, it's mostly focusing on your thesis.
Okay, thank you.
Hello. Aside from the master's program, I wanted to ask if there's a way, now that you're in your residency, to volunteer somehow in MSF's work in Athens. Like, I know that there are some centers of MSF working in Athens. Is there any way you could volunteer, even in your free time or anything, without a contract? I mean.
As I mentioned earlier, MSF is a bit picky with the concept of volunteering. They do not prefer volunteers. They like to have permanent staff because they train them very specifically. However, there are options to volunteer, not medical. You can volunteer through a master's program in the MSF offices, not in their clinics, not in the camps. For example, I will be volunteering as part of my, because the master's requires some practice hours, so I will be doing that in, hopefully in the field of advocacy, because it's something I really like. But at the same time, I'm planning to do some volunteer work in the polyclinic of Doctors of the World, which is much more flexible.
So there is a way to remain active, in humanitarian help, even in your specialty. Okay.
There are ways,
thanks.
but it's very difficult to get into MSF if you haven't actually participated in a project and met the people. It's one of those jobs that I like to say that once you're in, you're in. But if you're not in properly, it's very hard to approach. Thank you.
Thank you again, Eleana, for joining us. Let's give a warm welcome for Ismini, that even though she couldn't join us either physically or online, she has sent over a video that explains everything in detail on how to secure a residency in Greece. Evita now can come on stage and represent her. Yeah, it's a film. Yeah. Yes. I wanted to.
Hi,
We had a
everyone.
technical
I hope you're all
issue.
well. My name is Ismini Zanaki, and I'm a resident in obstetrics and gynecology at the University General Hospital of Heraklion. First of all, I would like to thank the organizing committee for suggesting me to prepare this presentation, and I really wish that I was in Cyprus and shared it with you. I really hope you find this helpful, and if you have any questions, do not hesitate to contact me. I will have my contact details in the end. Before we start, I just wanted to point out that all the data that I have collected here are based on current laws and guidelines, and sometimes they might slightly change. So we need to always visit the official website before we apply for residency in order to get informed about any updates regarding the. So what is the process of applying? First of all, you can apply into your desired residency anytime, taking into account that you have all the required documents available. For us that we graduated in Cyprus, we needed first of all our medical degree. Then it was required to officially register into the Cypriot Registry of Medical Doctors, as well as the Cyprus Medical Association. After that, we registered in the Pan-Hellenic Medical Association, and then we had to choose the hospital that we wanted to practice our residency, and we had to apply into the respective district's website. Now, for the international graduates, some further criteria exist, such as they need to have a language certification in order to practice medicine in Greece. Now, the selection process is very simple. Once you apply, then your name appears into a waiting list. The only thing you have to do after that is to wait patiently until your turn comes, and then they will contact you. So the chances of being accepted here are 100% if you are patient, and at the same time if you are careful. So please, before you send your papers for the residency application, check that you have all the correct documents so that you will not waste time by reapplying. Here you can see the available residency spots that someone can choose in Greece. It's almost everything. So as we mentioned above, you need to be a little bit patient until you get selected to start your residency in Greece due to the existing waiting list. Meanwhile though, you can still practice medicine, and some options are the ones that are mentioned here. You can apply for your rural service. There are 4 open calls per year where you can apply through the governmental website. Each time, different rural spots are available, and priority in the selection process is given to the older graduates. Therefore, it is not very easy for a new graduate to get accepted. However, it is not impossible. Additionally, you can work in private clinics as a general practitioner, or you can go abroad and start with your residence in another country, and then if you wish to come back when your position opens in Greece, in most of the cases your residency time abroad will be recognized. Another pathway you can follow is the research pathway, and you can start a master's degree or a PhD. Now let's get into some more details about the residency. The basic salary is approximately 1,200 euros, and you get paid extra for the 24-hour shifts that you have to complete each month. Usually the residents, they have around 6 to 7 shifts per month, which is approximately an extra 670 euros. But of course, they can work more shifts if they wish, which is something very common due to the lack of personnel in Greece. Working hours are Monday to Friday from 8 o'clock in the morning until 3 o'clock in the afternoon, and when the resident has a shift, they have to stay in the hospital for 24 hours. Shifts can take place during weekdays or during the weekends, and if they are taking place during the weekends, you get paid extra. The duration of each residency program now is different. Some examples are mentioned here. So, for someone that chooses obstetrics and gynecology, the training lasts 5 years. For someone that chooses ophthalmology, it is 4 years. Internal medicine is 5, endocrinology is 6, and there are many other examples as well. Each residency program has an official curriculum with all the topics that residents need to encounter during their training, ensuring that way that the trainees are exposed to as many as possible subfields of the desired residency, and they are well prepared to deal with as many cases as they can. For their professional development, residents in most hospitals are offered weekly educational sessions, which they can be both theoretical and practical, and they are usually organized by their clinic. They have research opportunities as well if they are interested to follow, and they can attend and actively participate in conferences of their field by presenting, for example, unique cases that they might have seen during their practice. Here is an example of the residency program in obstetrics and gynecology. An official curriculum like this one exists for each specialty, as I mentioned before, and it is being updated when needed. And many different examples exist of what can someone do while they're waiting for the residency spot. Here is my pathway up to now. So after I got my medical degree, I immediately applied for my residency to the hospital I wanted, because I mentioned before the waiting list, so this had to happen fast. And at the same time, I applied for my rural service because we finished in June, so there was an open call these days. I was, while waiting for the results of my rural service, I was practicing obstetrics and gynecology at a doctor's private practice. And even though I didn't get accepted in my first application, because again, if you remember, the older graduates have a priority into getting accepted, I got placed at a rural health center in my second try, but at the same time my residency spot opened and I didn't start with my rural practice. This is why I have to do it in the end if it is still mandatory. So now I am a resident in obstetrics and gynecology at the University General Hospital of Heraklion, and currently I am placed at the Clinic of Surgical Oncology because, as I showed before, in the official curriculum that we have, residents of OBGYN need to start with their 1 year general surgery and breast pathology practice. Last but not least, keep in mind that there are plenty of other opportunities you can take advantage of as a graduate. You can work in the medical field through the various pathways that we mentioned above and plenty more. Or you can continue enhancing your academic skills by starting a master's degree or a PhD, or you can present your work in conferences. So this is a small insight regarding medical residency in Greece. I hope you find it helpful, and please do not hesitate to contact me if you have any questions. You can see my email here. I wish you all good luck with the rest of your studies, and thank you for your attention.
That was his great speech. Now we are going to welcome Karin, but Elvida Vriza is going to represent her since due to time differences with Canada, she wasn't able to be with us today. Okay.
So hi everyone. I'm going to talk about the medical residency in Canada on behalf of Corinne since she couldn't be here. So for any questions that you have, I won't really be able to answer them. You can just email her. We're going to have the email in the presentation in case you have the questions. Okay, so let's start with the criteria to be eligible to apply for residency in Canada. First of all, you have to be a Canadian citizen or have a valid Canadian permanent resident card, which is kind of like the green card we get here. That means that you have to stay in Canada for approximately, oh, nice, wait. Okay, all right. Sorry for that. Okay, so as I said, you need to have a Canadian citizenship and also either have the card, the PR card, which is like the green card. So you have to stay in Canada for approximately 5 years and complete like the 700 days. And we have provided those websites here that you can look at. And you also have to graduate from a medical school that is registered in the World Directory of Medical Schools, which is our school as well. And then some very, very important factors that you have to take in consideration are the exams, the MCQEE1 and the NAC exams. And according to the provinces you want to apply to, you have to take some additional exams, like in British Columbia or in Nova Scotia, there are different exams that you have to take. So let's talk about the first exam. It's the Medical Council of Canada Qualifying Examination Part 1. To take the exam, you have to pay approximately 1,300 CAD. All topics are included: internal medicine, OBGYN, pediatrics, surgery, psychiatry, and ethics. And you really have to have a special focus on ethics, and especially Canadian ethics, because they really think it's important for the exam, and it takes a huge part of this exam. So about the structure of the exam, it consists of two parts: multiple choice with 210 questions, takes approximately 4 hours. And the second part are clinical cases, 38 clinical decision-making questions. And they're scored out of 400, with the highest scores being between 235 and 270. And especially for IMGs, since it's very competitive, you really have to have a high score. And the passing score is 226, and it changes according to every year and how the participants do. Then the second exam is the NAC exam, the National Assessment Collaboration Exam. Costs 3,000 CAD and consists of 12 OSCEs, 12 OSCE stations, like the ones we did here during third year, I think. And it's scored out of 1,500. The passing score is 1,374. Now, how do the stations work? Each station includes the examiner and the patient actor. We have 11 minutes per station, and you have 2 minutes to read what the scenario is going to be, kind of like what we did in the third year. And then each station is different. You're required to have either a medical history, physical exam, differential diagnosis, or to interpret a type of imaging, X-ray, MRI, CT. And some stations also require you to know about psychiatric evaluation and ethical dilemmas. And I have to point out that that's an important part of the exam. Then about the CAMeSM, it's the Canadian Residency Matching Service, and you can find all the information you need on this website. So physicians apply there, the scores are released there, and then they're transferred to the CAMeSM. And all the details about residency programs, salary, deadlines regarding matching or data reports of previous years are included there. So as I mentioned before, in order to apply as an international medical graduate for Canada, it's very competitive and the positions are restrictive. However, something that is quite good is that you're not competing with the Canadian graduates or competing with other IMGs, but again, it's very limited. And what they really value is for you to have experience, like clinical experience there. So some medical specialties are very competitive, even for the Canadian graduates. And the ones that are more IMG friendly are family medicine, psychiatry, and internal medicine. Here is a preview of the CAMeSM and how it looks according to the different specialties and who IMGs or Canadian graduates matched. You can find this all in the website we've provided. And you can also find about the salaries of each medical specialty, and and some other kind of policies. Now, as an IMG, the most important factors, as I said before, the NACs and the MCQ-EE scores. You also have to have some research publication, good reference letters, and especially for the reference letters, it would be better if it was from someone inside the system. Have extracurricular activities, either in your medical school or afterwards. And a Canadian observership or an elective would be even better. So the electives, you have to do it as a medical student. So if you're interested in Canada, you should try to look for electives from now and from your clinical years, like 4th to 6th year. And in order to get into an elective, you have to pay a fee. Usually the fee is quite high, but it's worth it because it gives you a great start on. And then another factor that it's not like so difficult for us is the language barrier. We're lucky since we do everything in English. And some provinces do not require you to have an IELTS, just to have your English from do medical school in English. However, the British Columbia, Nova Scotia, and everything that is written here, they require a valid IELTS or OET or TOEFL, and Quebec requires a knowledge of French language. I already said that. We have restricted positions for IMGs. However, you only compete against IMGs. And something that usually IMGs could do is have an extra clinical practice after they graduate there. So they can do either a clinical practice or a training, 1 to 3 years. That also helps them to get maybe a permanent, the PR card that I mentioned. And something new that we learned about is this postgraduate medical education program that is offered by the University of Ottawa, and it's also sponsored, because if you want to do clinical training there as just after you graduate, you have to be responsible for your own expenses. However, this university will kind of fund you to either have some opportunities with a clinical practice or maybe do some fellowship. And this will, of course, increase your chances of matching in Canada. Here is a note from Karine that at the moment she's working at a family medicine clinic in Toronto. She has completed the 2 required exams by all provinces. She's planning to apply to other provinces or require additional exams. They're listed in the parentheses, and these exams have to be taken in December before applying in January. And the reason for this is to increase her chances of matching, and she will be applying to the match cycle the upcoming January. Matching in Canada as an IMG is very competitive. Students that studied in Canada do the MCQE exam, one exam only, and have priority over IMGs. In case you did not match in the first iteration, there will be the second iteration to apply to. Meanwhile, you can opt to do a master's degree or clinical research, so that way you can increase your chances, maybe meet some mentors, and gain some good recommendation letters. And there's also telemedicine at walk-in clinics, so you have to pass at least one of these exams to be able to work there. And here is a diagram of how the match timeline goes. And continuing the notes, so she knows that how tough it is after medical school, especially if we intend to go to a different country for residency. And while she was in Canada, she didn't find any, she had to find everything on her own. Hopefully now you have Karine, and you can always email her to gain some advice for any further questions you have. Thank you.
Thank you, Karine and Evita, for this informative speech. Now we will welcome TJ Brockman, but again, it's going to be a presentation with a video on each slide because she couldn't be with us here today.
Hi everybody, welcome to my talk. It's going to be very informal, just like me kind of having a chat with you guys. Sorry I can't be there in person. I'm actually on my way to another holiday, but some of you may or may not know me. My name's TJ. I used to be a student in Cyprus myself. I graduated in 2021. I'm now working in the UK for the last year. And I just thought I would give you a little bit of information of how to apply to the UK, what is the usual route, what route I took, what I'm doing now, am I liking it, am I not, and what I'm going to do after. Hi everybody. Okay, before I move any further, I think it's really important to know how the UK training system works. It's quite different to what we'd be used to in Cyprus or Greece or even in the US or some of the other European countries where you just pick your specialization, you apply for a job, you work in that hospital, you specialize, and that's it. That's not how it works in the UK. So for a UK graduate from medical school, they do 5 or 6 years depending if they're integrate, then they apply for their F1 and F2 training. In the UK, you get a provisional registration when you graduate. So that means you're not fully registered with the GMC. You have to complete at least one FY1 year, as you can see hopefully on the screen now. Then you're granted your full registration, you complete a second year, F2. After these 2 years, you're fully eligible to do any of your specialty training, including, let's say, general surgery, GP, IMT, internal medicine training, whatever you'd like to go into, anesthetics, ED. Another tip is, normally these foundation programs years are split into 3-4 months. So you do 4 months, 4 months, 4 months, and go from there. As you can see on the slide here, the overview of the specialty, I just was kind of making it clear that it is kind of a long road, especially in the UK. You have to do minimum 2 years, then the time you apply for specialty training, it's not the easiest. You could be looking at 3, which is the minimum, which is GP. I think that's a really good route. 3 years goes very quickly. Or 9, if you're looking at some of the surgeon jobs, Max Fax, ENT, yeah. A lot of people take gaps between that 2 years and applying for specialist training. A lot of people locum. I don't know if you've heard that term used before. A lot of people do clinical fellow years. So they just get like a bit of extra experience, or they don't know what they want to do, and they just kind of just work basically as a junior doctor before making any decisions. So the main reason you're here, how to apply. As you could see before, the usual route for a UK medical student is you do 2 years, F1 and F2. For Cyprus, at the moment, we are only eligible for an F2. They feel as if, because we've done a 6-year program, that we have an intern year kind of within our 6 years, even though we don't. So remember that. They kind of expect a little bit more than what yourself you expect. So you are only eligible to apply for an F2 year, which is called an F2 standalone, which means that you only do 1 year and you're eligible to start training. When to apply? When I was doing it, that was in 2021, the application date was the end of December. I know for this year, the application was maybe middle of Jan, end of Jan, so you just kind of need to keep an eye out, especially on the website. And they normally have all of the dates, so it's very simple to keep on top of. When you apply, we can go through the application process, you're applying to work all over the UK. So you will be able to apply for jobs in Wales, England, Scotland, and even Northern Ireland if you get through the process. So always remember that you don't just have to work in England, let's say, or we'll get to where I'm working is not actually even on the mainland. So that's always something good to remember. What you need. When I was applying, I needed the IELTS, the IELTS English exam. Sometimes that changes. Some universities get away with not using it. I know you just need to be extra sure. I needed it specifically for my GMC license, but please be careful of that. The other 2 things you need is an SJT and an interview. So when applying, your process will go through. They will decide whether you're eligible or not, whether your country is eligible or not, whether your country's in the UK, etc., etc. You will then be booked to do this SJT, which is kind of like an ethics type exam. Very, very common in the UK. They love it. Very similar to where the NHS culture is, what they like, what they don't like. So I think it's quite easy to do well in. Do the practice exams, have a read of everything. Don't be too worried or stressed about it. It's kind of have to wing it a little bit. There's really good YouTube videos online also. I would highly recommend watching those. And yeah, also I think the GMC is a really good thing to read. They have like a full booklet, and I think that really helps also with these scenarios. If you get a good enough score in the SJT, you then will be ranked or put forward to book an interview. You then will do the interview, and if you do well enough with that, you'll be ranked compared to the other applicants and maybe hopefully offered a job. So the interview overall I did the interview, it was quite intense. It's not just asking about yourself. They ask you at least 1 or 2 medical type scenarios. They also ask you an ethical scenario as well. So just be aware of that. They asked me a lot about my CV. They asked me a lot about why I felt I was ready to be an F2 in the UK compared to the F1 starting. So just be aware of that in that region. Visa. I'm super lucky. I'm Irish. I didn't need any visa to go to the UK. We can just live there and work there like Ireland. So you guys kind of need to sort that yourself depending, and especially because of Brexit now. You also need to be GMC registered the time you start work, which would be August. So what are the chances of getting a place? If you have a high SJT score and a good interview, you're basically offered. You're going to get an offer. So it's quite a good chance, and I don't think it's the hardest of them all in the UK. Selection process. I think we've gone through this a little bit before. So as I said, you normally apply end of December or end of Jan. It's on Oriel. That is the name of the website that you do your application. Your application is long listed. As I've said before, they check, making sure you have all the criteria that they needed. You sit this SJT, situational judgment test. Depending on your score, you're either offered an interview or you're not. A 20-minute interview. If you do well in that, then you rank your preferences and then you're offered a job. So there's like 2 rounds, and it depends on your SJT score what jobs you're offered. As I said to you before, they ask a medical scenario. Tip is what I've been taught and what was for me also in the interview. They normally ask the emergency scenarios in the Oxford book. So if you know them in and out, you're guaranteed to at least have something down in the interview. So I would recommend that, especially if you've an interview coming up soon, because I think I know the SJT results came out last week. So hopefully whoever applied and wanted to do that did well. So yeah. What are your chances of being accepted? As I said before, you really, really need to have a good understanding of the SJT and how the UK system works and what they want you to answer the questions. And my number one tip would be not what you would do, but what you think they want you to do. I think that's really important, kind of understanding that the UK has like a tier system of who you go to report things. So look into that. I think a good CV with any UK clinical attachments obviously would come really handy. So I mean, if you're in second, third or fourth year and you're interested in going to the UK, I would start to look into going to do a clinical attachment now. I think it really makes such a big difference. As I said before about the scenarios, they love ATE assessments. I think our uni does too, but just so you're aware. Also, as I said before, they really did grill me on why I would be better than an F1, what I would bring to the table, am I ready, etc., etc. So just be prepared for a few maybe challenging questions or, yeah. So can you work while waiting for documents? In the UK, you cannot work as a doctor unless you are licensed and registered with the GMC. So you could do a clinical attachment. So basically you'd still be a medical student, but still be shadowing. They're never any harm. They're really great. I did 6 weeks shadowing before I started work. Most F1s or F2s, even if you're coming, do a little bit of shadowing just to kind of get you to know the hospital, know the system. So I don't think any extra attachments or shadowing is ever a bad thing, especially if you're waiting for documents. As I put kind of in red, next year I think things will change. So you kind of need to be aware of researching everything. They're bringing in this UK MLA, which is very similar to the US MLE, and they just want the standard medical evaluation for everyone coming to the UK and for the UK medical students. So everyone applying, let's say F2 standalone, for the normal F1, F2 will have to do this. So I don't know what it's going to be like. I don't know how it's going to work. I don't know anything about it, but I know it's coming into place in 2024, and you really need to just try and research as much as possible, because if you apply next year, you guys, whoever does that will be the first to do that, really. Okay, now the things you guys normally want to know the most: salary, not great. Don't be expecting much. F1s normally start at about 30. F2s obviously start on a little bit more, maybe 34. Those salaries are without banding. So I'm trying to think, a job, let's say if you have a psych job for 4 months, you probably won't be on any banding. But if you're in an acute medical ward or a general surgery ward, you might be on some banding, so you might get a little bit more than that. Remember, rents are quite expensive, so when you're applying for your jobs, be careful of where you're applying for. You know, like if you want to live in London and think you're only going to earn 30 grand or 35,000, it's actually not that much to survive there. So just kind of be careful in that aspect, where you're ranking, what you want to do, etc., etc. There's always extra shifts sometimes going in the hospitals, called locum shifts, where you can earn extra money, but sometimes you actually just want to have the time. So working hours. Most basic working hours are 40 hours a week, but that depends whether you have nights, whether you've on calls, which 12-hour shifts, or whether you have weekend shifts. So it really does depend on your rota, but the minimum starts with 40 hours and you can go from there. Okay, annual leave. I think the annual leave is quite good. You get 9 days per 4-month rotation, so 27 in a year, which isn't that bad, especially when you have days off after post nights and things. It makes quite easy to get the time. So duration of junior doctor training, as I explained before, you can either do 2 years, F1 and F2, or 1 year, which we're only eligible to apply for in Cyprus. They're really good in the UK about professional development and support. We get study leave mainly when you're in F2. We get weekly protected teaching. In my hospital, I have it every week on a Wednesday for 2 hours, and that's fully protected. So you are allowed to leave the ward and there is no issues if the nurses can't contact you, because that is protected teaching time. We also sometimes have extra teaching on a Tuesday. There's radiology teaching every week. There's obs and gynae teaching every week. On a Friday, there's teaching for an hour and a half. So there's a lot of, extra development always there and always available. We all have clinical and educational supervisors, as I'll show you as we go through. And we all have to do an online e-portfolio. That is how they keep track of what we're doing, and that is how you pass basically your F2. Is that it will be checked at the end. So you need it for all of your appraisals and further training. Also, there's many opportunities facilitated by the hospital, especially my foundation program director is constantly emailing things that we can do, that we can help with. We can help with audits, things like that. It's also important for portfolio. When you get there or you start working, you soon realise there's a lot of added extra things that you don't really think about. You think you just go to work and come home, but the e-portfolio takes a lot of time. Now, what am I doing now? Basically, I'm an F1. I'm currently working on AAU, which is an acute medical unit, and I'm working in Jersey, which is an island basically off the UK. It's in the Channel Islands, and I will be going into an F2 post in August. That's a picture of myself and my friend Kirsten, both kind of tired, but still smiling after a long 12-hour shift. Okay, after me explaining all about the F2 process, you're thinking, surely she just did that, but I didn't. The interview for me went terribly, and I was kind of delighted. I didn't really want to start as an F2. That is my personal opinion. I didn't think I would be ready. I thought, oh my God, I've studied abroad. How am I supposed to be ready then? The UK medical students have studied in the UK. I was like, oh my God, panicking. I was like, well, I just applied to Ireland. In Ireland also, you would have had to start as an F2, the equivalent we call an SHO. I really didn't know what to do. So there was also this different option called Gateway. They are called the Gateway program. You just Google that and it comes up, Gateway Junior Doctors. So basically, they were set up a few years ago to help and facilitate doctors that have studied abroad. That is their whole goal, especially if you're eligible to work in the UK, and that's kind of the tricky thing. I'm lucky because I'm Irish, I didn't need a visa, so my eligibility was perfect. So it's a 2-month or 24-month or 2-year program. So they put you in a place for 2 years. And basically at the end of it, it's an equivalent to an F1 and F2. You get this CREST sign-off and you're eligible for specialisation. So that is what I did. I will explain now how you apply it, how you do all of that. Okay, very similar to before. You are eligible to apply for a Gateway if you've completed your degree or in the last final 6 months and you're waiting for your exams. You need to have the right to the work in the UK, basically. That's the issue. So you need to have a UK passport or have your visa sorted or something. I would always contact them and ask them if you have any questions. They're so nice. They're so helpful. They did everything to help me. And yeah, I loved them. So they're always there via email and they'll answer anything. But if you're from the UK, I think it's a great option to look at because basically you get to do an F1 and F2 equivalent, whereas with the F2 standalone, it's not possible. Also, another really good thing is they don't just start in August like all the other F1 and F2 posts. I started in March. You can start any time of the year, which really also makes a difference. So you're not under kind of stress. When I finished med school, I think it's a really challenging time. I feel like you think you're very unsettled. You don't know where you're going. You don't know what you're doing. This is totally normal. So embrace it. You're kind of all over the place. I had that for a few months. I was just getting my license. I was applying to this Gateway. I applied in October. I applied for my job in Jersey in November and I started in March. That shows you sometimes how long this process takes. So be aware of that and don't be nervous. So what you need to apply is you need your full GMC registration, easy to get. You'll need the IELTS English exam to prove that you have the English competency. You need your CV and the eligibility to work in the UK. They do an interview with you and decide whether they're happy to take you on the Gateway program, and then they go from there. So how it works is they have a selection of hospitals that need F1 and F2 posts filling. So they send you out on a weekly or bi-weekly basis emails saying, we have a place in Wales, Aberdeen, Nottingham, wherever. And then you apply with your CV to those hospitals. So you get a bit more of a choice. So I applied my CV to Jersey. I then did an interview with Jersey, got accepted, and now I'm here. So it's another really, really good option. Okay, as I was saying before, I think kind of it can be like a very scary, very intense, just a very weird time. It's not as simple as when you study in your home country and you know the route and you go and do your specialisation and that's what everyone else is doing and that's that. For us, Everyone's from different places, everyone's going everywhere, and it's going to just take longer or shorter depending on the path that you take. So kind of remember that everything's meant to happen for a reason. I was maybe like a little bit disappointed I didn't get the F2 standalone, but in the end I was absolutely delighted because it's not actually what I wanted, and what I'm doing now and where I'm working and all of that has just made it so much better. So if I could go back and make the same choice, 100%. If I could do something different, I would just kind of know that I should just trust myself more, go with the flow. It's all going to work out. I'm doing what I can and go from there. It's very easy to look at everyone around you and think, oh my God, everyone has a job. What am I doing? I'm not doing this, whatever. But it actually isn't like that. So just take a little break when you finish med school. Most of us have done 6 years. It's a long time. You lived away from home. Yeah, so I just think sometimes a few months is needed. Get back into a routine and go from there, and try not worry, even though I think it's easier said than done. What is something that you guys as future graduates need to be cautious about if they take a similar route? As I said before, it's easy to look around at colleagues and think, oh my God, everyone has it together, everyone's in a job, everyone's doing this, oh my God. It's not like that at all. I was kind of ready to start work by March because I was in Ireland, all my friends were working and wanted something to do. But some people it takes 2 months to start working, it takes a year, it takes 2 years. If you want to go to the US sometimes, oh my God, it takes years. So it's a big change, it's a big step. It's like a really big time in your life, so don't put yourself under any pressure. What is the hardest part until now? I think I've spoken about it a lot. I think the transition between uni and starting work for me was the most difficult. As I said before, no one knows their plan, and if they do, great, but sometimes it changes. So start with plan A. If something goes wrong or it's not for you, there's always plan B, C, D. What's next for me after F2? I would love to tell you, I have absolutely no clue. I might locum for a few months. I might do another year, clinical fellow year. I might go to Australia. I honestly have no idea. And that's great. I don't think I need to. There's no pressure. You can just decide when you want. I think that's really, for me, a nice thing about the UK system, is that you can do like a few rotations, get to know a few specialities, kind of decide what you like and then go from there. Once you've completed F2, I said before, you can apply for specialist training. Each specialty training, they're kind of grouped into like core surgical, internal medicine, IMT training, GP, ACS training. They all have different application processes, but in my opinion, just try and focus on starting as a junior doctor and going from there. Either apply for F2 standalone or the gateway, and the gateway is a really good option, especially if you're from the UK. I really highly recommend it, just because they're a really good support system as well, and they do a lot of the work for you, especially with communicating with the hospitals and all those other like nifty things that you just don't really want to have to do. So that is my tips. There's just one last slide there explaining about, once again, how the system works. I think you know medical school 4 to 6 years, F1, F2, 2 years, then your specialist training depending 3 to 10 years, GP is one, like the 3-year one, and most of the others are looking at 8 years, and then you're a consultant. So as they're saying, from 40 years plus normally. So be aware of that. I don't think many people want to become consultants in the UK at the moment. They're just enjoying being a junior doctor, so they're training and then going from there. Okay, nearly one last slide and we're nearly done. So, other opportunities for EC graduates. You know, I think especially nowadays, a lot of people are thinking maybe medicine actually isn't for them the time they graduate. So there's always different options, and I think always do what makes you happy. I think if a job doesn't make you happy, then it's not really for you. So you can always do a master's when you graduate if you want. You want some time to figure things out. You can do a PhD. You can do a fellowship, or mainly in the US and Canada, they call them fellowships, or shadowing periods, as I said before, clinical attachments in the UK to see if you like it. Do you even like being in the UK? Is that what you want to do? You can do some research. You can locum. I would be careful to locum having never worked in a UK hospital before. I think that's really tough. I think they expect a lot from you, and remember, you're being paid more than everyone else, so there's a higher standard. Clinical attachments I mentioned before, and there's always non-clinical jobs such as like medical sales or pharmaceuticals, things like that. So there's many different options. Always look in to that side and see if there's something else you'd like to do. I put a few links there, or websites I know for a fact that have a lot of information. YouTube is great. There's loads of people that explain everything in detail on YouTube. There's a few Facebook pages. The Gateway Doctors has like a page where they have a few people on it, and they're quite good. You can follow them on Instagram and things like that. So I think that also really helps. Finally, the end. So I hope it hasn't been too long. I hope you've learned something. I've left my email there on the last slide, so if you have any questions or you really need to ask me something, or you can just like follow me on Instagram or Facebook and ask me, it's no issue. So yeah, good luck. Number one tip would just to be enjoy med school, because I feel like it's the best time ever. You've no worries, you don't have to worry about work, you don't have to worry about anything. So yeah, really just enjoy it, have a great time. And if you, the people that are graduating this year, I know most of you, so always sending my love, and maybe see you for graduation. And yeah, thank you so much for having me.
Thank you, TJ Brockman, for this lovely speech. Now we are going to take a 10-minute break. Basically, we are going to be here 10:06. And we will continue with Dr. Andreas Yalouros. we will continue with Dr. Andreas Yalouros, and he is going to talk about guests from Penn State in the USA. Thank you.
Thank you very much. Hello, everyone. First of all, I would like to thank the organization committee, all 32 people that they work and invest a lot of time on it, okay? And it's been an amazing job, as I am here in this university for the last 9 years. And we are doing this CAMeSM Congress for a long time now. It's the first time that the only request, it was budget. So in the past, we had a lot of requests, you know, we need to help us on this, on that. This time, they only ask for money. So it means that you did a good job, right? So today, I'm going to give you a story about a great initiative that we are very, very excited. And Rotem was also involved on it, right? And the story starts by, after we finished the first cycle of operation, which means the first 6 years, we had accreditation from the WFME, which is the World Federation of Medical Education. And they just, you know, ask a couple of questions. Actually, it's a tough days because they ask about curriculum, they ask about student services, they asking about everything. And all of a sudden, when we were bombarded with questions, they asked, where is your portfolio? So I remember that Dean Johnson is not here. He said, portfolio. And I said, portfolio? Portfolio? So he said, they might think about the logbook, right? So we proudly gave them the logbook. And they said, no, portfolio. So I Googled portfolio, student portfolio. And I realized that we don't have anything like that, right? By just Googling, you will end up having an idea that the portfolio is just an online platform that you just uploading documents, right? Uploading grades, uploading snapshots of events, right? I did a paper. I was involved in the surgery club, full stop. So we started researching. We started researching about what other universities are doing, how we can differentiate from the old school way of portfolio. And we're ending up that the trend and the most useful thing is to have something that is called career management. After a couple of discussions with 3 brilliant minds from my point of view, we end up that the best term is the self-career management. And in order to do a successful self-career management, first of all, you need to know what is important to have in your educational arsenal in terms of, curriculum designs and all that stuff, as well as what is the key things, the recipe to the key to success of being able after 5 years if you are a dental student, 4 years if you are a nurse, 6 years if you are a medical student, able to compete others, right? Because a medical degree is just a degree. You have a diploma, now graduation is around the corner. Thank you very much. What's next? It's a different story to have a degree. It's a different story to have a successful career. So we are searching a lot, to be honest, how we are able to give the reflection part, how a student feels about an event. For example, first day in clinics, year 4, day 1, I tried to take blood from a patient. My legs were shaking. It's a reflection. But then, after a couple of times I did it, I'm confident. So the key to success is that it's a complex thing to be a medical student or a healthcare worker or a future healthcare worker, to be more precise. If out of this mess you are able to find a way to do it, then you're building confidence. Once you build confidence, then you're 100% able to do it again and again. That's why the golden opportunity is if you are doing it once, you are able to repeat it and repeat it. So we were brainstorming for a long time, every Thursday for a year now. And we found out that each student has a different starting point. Some students came up here with a degree, some others straight from the high school. Some others change from nursing, from law, we have great examples, to medicine. So each student has a different starting point. The transition period, all right, first year, they are very stressed. Parents are more stressed than you, by the way, because they're doing, and you are doing an investment. You are investing time, the parents investing money. So what is the return of the investment? You're doing all these sacrifices. You're, doing everything needed to pass the exams, to get as much as skills, soft skills you can. But what's next? Are these things enough to go out there and, there is one position? Is it going to be the position tailored to you? No. You need to adapt and be able to compete others and grab this opportunity. So we centered to make you shine. For example, Rotem was on the organization committee of the CAMeSM Congress. She just have, a paper saying that. It's not validated. So we think pretty much all of these aspects to validate everything, to make you able to show your strong points, make you also visible your weak points in order to fill in that gaps and then to be ready to compete others. So I'm not going to waste a lot of your time. I prefer to pave the way for the discussion because these three guys that we are spending my Thursdays together with them, which were hand by hand in the development of this platform, and are waiting now. And I'm talking for the persons, Michael Marcus, Don Hampton, and Ramsey Wells. These guys are from three different angles, adding value to this development. They have a great experience about what is needed to compete others out there, why career management and not portfolio, why need to have a lifelong document that you can use afterwards, all right? It's not a piece of paper anymore that you're just printing your CV, sending it, or wait for them to give you the chance for an interview. In our days, you can send them a link using a career management platform that you will tailor according to the position's needs, and then you're going to be able to show your strong points. Strong points like, I was the best in biochemistry in my class. Okay, can you prove it? Yeah, there are now tools that you can validate your scores and you can compare your scores with your colleagues, as well as international standards, EU standards, and US standards. That's why we have, and we are very proud about the collaboration with PenSource, and I want to welcome Don, Michael, and Ramsey in our company. Hello, guys.
Hi, good morning.
Hello. We have the students here waiting, but I wanted to give you the first question, and then I'm going to sit next to Rotem, all right? So I'm going to give you the first question of the day. When is the best time to start building a career? Is it too late for me? Because I just became a lecturer 3 years ago. So is it too late? Or Rotem is about to finish the degree in the next few weeks. So is she lost the train, or there is much things to come? I'm going to have a seat, and then probably I'm going to have another question.
Okay, well, the best time to really start a career and start planning for your career is the earliest point that you can do it, because starting medical school, in order to get admitted, you need to have a vision of yourself as a doctor. You have to have motivation for going through. But what that doesn't do is tell you what you need to accomplish over the period of time that you're in medical school and you're applying for your next job, which is the residency internship. And it also doesn't tell you what you're going to need when you're in actual practice. So from our standpoint, and most experts in the field, they'll tell you that you start from day one, and as you learn more, you're going to change and develop over a period of time. To give you a short answer, the best way to approach it from all of the people in the field is to understand what you're going to have to perform when you're actually a physician. And I'm going to give you a couple of statistics that you probably know, but they're kind of very difficult, because what it says is that your education never stops. It's estimated that medical knowledge increases at every 73 days. It doubles. And it's with that situation, you can't expect to keep up with everything. So your life is going to be a series of getting prepared and updating yourself constantly. And to do that, you're not going to have a teacher guiding you. You're not going to have an authority telling you what to do day to day. So in the estimation of the people that employ you and work with you, they're going to want to see somebody who is prepared to learn and to stay up with the times. It's not easy. Don and I have been in the tech business for a long time, and we've had to change our knowledge constantly. If we go back 10 years, we'll find that very little of what we learned 10 years ago in terms of details are important, but the principles are the same. Don, do you have anything to add to that?
I would add this. While it's true to start early, it's never not a good time to get started. And the career self-management is really all about taking that step, take bite-wise steps and accomplish those, and you're making progress towards finding that career or acquiring that position that you want. And that's really what we're all about, is the agile approach to career management. That's why we call it career self-management.
Andreas, any you want to add to that?
Yeah, I have another question, to be honest. Can you, in brief, explain us what is the difference between an old school portfolio and the self-career management to the students that we have now in front of us?
Well, usually portfolios are written when you're getting ready to apply for a job or to use it. That's really the wrong time to write your life story. If you want to write your life story, you should start writing it today so that the end picture looks good. If you're going to paint a portrait of yourself, you need to start off with the different layers that will add up to the final result that you want. So the difference is a portfolio without the self-management may be an accident, or it's something that happens without intentional. It's not designed, and as a result, you're really a captive of events that you may have experienced over a period of time and put you in a different direction. Throughout your career, employers and trainers in the medical field are looking for people who can manage themselves because they don't want to have dependent individuals. So the key to self-management is to design what you want in the end rather than accepting what you have at the end of your education.
Yeah, if I could add to that, if I could boil it down to the lowest number of words, a portfolio is just a collection of documents. It doesn't mean anything other than it's a collection of documents. Career self-management is an intentional path that you lay out. Your path may change, that's fine. It's based upon your experiences, and that's why reflection plays a really key role in career self-management. You're going to learn, you're going to observe experiences, and by reflecting on those, you get to know yourself and you get to know your real, true aims in life. And so, bottom line, documents versus an intentional path. That's how I see it.
Yeah, and we use the word journey quite frequently because it is a journey. And a journey has a start where you are today and a destination at the end. Without a destination, it's unplanned, and you can wind up anywhere. So if you want to have a result that is satisfying and worth the investment that you've made in your education, you should put your plan into effect so that your intentions are carried out, so that the end result is something that you will find enables you to have the lifestyle and career satisfaction that you're looking for. And by the way, self-management does not end in the university. Self-management is something that goes out throughout your career. If you look at the constant change in medicine, there are very few doctors today who will tell you that after 5 years or 10 years, that the practice in my specialty resembles what I started out with. So you're going to have to make a constant set of adjustments. And that's part of the game, and that's part of the requirement for being a successful member of group practices and the other hospital staffs and other organizations that rely on the professionalism of the members. Keeping up is a major job and a major time commitment for everybody. Your education doesn't stop when you leave the university. Andreas.
Any questions from the audience?
Hi. I do want to ask, so what it is that I would need to do to make me more desirable by a position I want to chase? So not just a student, because everyone here is a student. What makes me more unique?
Well, the first step is to understand that each specialty or each group of specialties has certain characteristics that are very important. So you have to understand those in order to get the experience that you will need in order to be successful in that field. And if you look at the students in the sixth year, you don't have a lot of time to plan. So at this stage, you have to take what you've already accomplished. However, we find in different countries that students will say, I'm not really prepared to go out and get the specialty I want, so I'm going to take a year off and get experience in research or in some other volunteer work or studies that would qualify me. So it's never too late to get your dream, but you need to have a dream first. And working towards that and understanding what's required is something that will take experience. You don't know until you've experienced the practice. The people on the other end, the specialists who run hospitals and recruit people for practices, they're looking for independent individuals. So it doesn't always matter the length of your journey, as long as at the point that you present yourself, you have the qualifications that will lead the practice to accept you as somebody who is independent and can manage your own career without and to advance the quality of the practice. So a lot of this is a learning experience, and it's never too late to start. In the first year, yes, you have time to explore your strengths and weaknesses, and to prepare on a slower basis. But as you get up to a point where you need to go out into the world of residency and internships, you need to be prepared to be a performer. Otherwise, you will not have the career that you want. You'll have a career that somebody else has selected for you. Don, any?
Yeah, I guess what I would say that's really important to me is awareness. The knowledge that I need to do something, as Andreas said, college is a huge investment. Your time, maybe your money, if you have a loan, And you got to make the best of it. Awareness to me is really key about, I need to know that I need to do something. College is more than just education. It's the start of your career because it's your career prep. Like in my case, I spent 9 years going through undergraduate and graduate degrees in the scientific and engineering world, and now I'm in software engineering. So your path may change, but all of those years that I spent helped me, and it continues to help me in today's world. Technology changes just like medical knowledge. It changes, just seems like daily. Now look at generative AI. It wasn't there a year or two or three ago. So I would just encourage anybody, especially younger people, freshmen and really early stage college students, to really and truly consider what I need to do to make me shine. Dean Johnson emphasized to us, whatever you do, I want my students to shine. And you should have that same attitude. I want to make myself shine. And you got to figure out how to do that. And that's kind of the things that we're interested in. And we do.
And you can build these skills over your career. That's the important thing, to realize what it takes, and then to fill in the holes. Independence and being self-sufficient in the real world is really critical today. So self-management is something that you'll be left with for your entire career. Remember, the average working life is 90,000 hours. That's a lot of time to be spending at work. Now that's the average person. The average doctor spends more time than that. And from that standpoint, the self-education and keeping up to date with not only in medicine but in dentistry, it's a tremendous investment.
So to answer Rothan's question, I would say it's never too late to stop, figure it out, what you need to do to get that position that you want. It's never, ever too late. But do it. You got to be aware that you must do it. Andres?
Any other questions from the audience? Okay. So Don, Mike, and Ramsey, can you just give a last piece of advice to students that are from first, second, third, fifth, and sixth year of their studies? Just a piece of advice from each one of you, because I know that you all have a different angle.
Well, remember the Chinese proverb, 1,000-mile journey starts with a single step. And success and self-management are dependent upon having a plan and taking small steps that you can digest, that aren't too complex. So breaking it down into something that you can do and executing on a regular basis is very important. Also recording this and sharing this with friends, family, and other people to help you keep on track, because going through school is difficult, and it's a transitional experience. In education, the responsibility is usually for the teacher to drill the student. In adult learning, the adult has to determine what's important and be self-starting. So you're in a transition phase, and it's difficult to accept this because it's a complete change in roles. But from this standpoint, do it small, and do it regularly, and you'll arrive there.
I guess my advice would be, would still be, get started. Just get started. Know what the requirements are. Devise your plan to get there, and bite-wise, chunk by chunk, do it. And if you learn that maybe this is not really what I want to do, okay. Find out that next thing you want to do. Plan, execute. Right?
Yeah, I think I would just add to that it's not easy. Be prepared. You never know what is the thing that is going to separate you from another candidate, and you just have to have everything at your fingertips in order to put that forward.
Are there any questions from the audience? No. Okay. I would like to thank you very much, guys, for your participation. See you next Thursday.
Okay.
Thank you.
Ten-minute break. Thank you.
Good evening, everyone, and welcome to the closing ceremony of this year's Congress. I am Elena, and I'm here with my co-host, Ido.
Thank you, Elena, and welcome to all of you. We're honored to be here tonight to celebrate the success of this year's CAMeSM.
We have very special guests with us tonight. Please welcome two of our co-chairs, Daniel and Valerie.
Sit next to the piano.
Welcome, everyone, to the closing ceremony of the 2023 Cyprus Annual Medical Student Meeting. It has been a great success and an incredible event, and we're thrilled to see so many participants from so many different backgrounds and cultures. We had an amazing turnout. We actually had over 400 participants who are joining us in the event online as well as in person.
In the last 2 days, we had 6 free paper sessions with 22 free paper presentations and 8 roundtable sessions with 28 presentations, which provided a platform for students to share their research, ideas, and insights. These sessions were incredibly enlightening, and it was truly inspiring to see all 50 presenters and 24 faculty members engaged in the making. From the Scientific Committee for paper screening to providing mentorship for presentations, from sound technicians to public health stands. We would like to thank you all. This outcome is a testament to the diversity and richness of our community, and it makes me look forward for the next year's Congress.
So this year, we were also honored with actually having alumni as well as professors who were speaking at the Next Step session. They were giving the students some guidance on how to approach their career after the graduation. They gained insights about Germany, Greece, the United Kingdom, Canada, and different volunteering possibilities, as well as NGO work opportunities.
We would like also to take a moment to recognize the hard work and dedication for our workshop presenters, which are all here. Hopefully, some are missing, but still you guys are here, and you did a really great job. Your contribution has been invaluable for our Congress, and I hope that everyone who attended your workshops found them to be informative and engaging. In total, we had 13 workshops over the course of the Congress, covering a wide range of topics and interests from dental and medical topics.
In addition, we would also like to thank all of the volunteers who made this conference possible. Your tireless effort actually helped ensure that everything ran smoothly, and we could not have done it without you. In addition, our amazing network of organizers created such a seamless flow. In total, we had 59 volunteers who worked tirelessly behind the scenes to make this event a success. Thank you so much for your hard work and your dedication.
And now, we would like to take a moment to recognize the incredible work of the organizing committee and scientific committees. With their commitment and passion, we were able to put together a truly outstanding performance. It is because of their efforts we were able to have such a successful event. In total, we had 32 committee members who worked hard to ensure that this year's conference was unforgettable and gave up a lot of hours over the sleep while doing it.
We did. Okay, now we're going to have our host again joining us on the stage.
Thank you.
Thank you.
Okay.
I'm sorry.
So now, it's time to recognize the people who have made this Congress a success. First, we'd like to invite the committee members to come up on stage to receive their certificates by our lovely co-chairs Daniel, Rotem, and Valerie.
Read the names.
Okay, this one's? Okay. So, Anne Caroline Sommerfield.
Okay, so Αντώνιος Πίκουλος.
Δημήτριος Σημεωνίδης.
Μπέρθα Δημητρίου.
Δημήτριος Ξεζονάκης.
Ευθαλία Εμμανουέλα Χρήσοφος.
Ευθύμιος Καραγιάννης.
Έλιας Ζρέικ.
Φάτιμα Τζαμάλ.
Φώτιος Χαρίτος.
Γιάννης Απέργης.
Άντζη Τζούχα.
Κατερίνα Ματζαρίδης.
Λάνα Μπόλης.
Λορέντζο Ντεφρέια.
Μαρία Ηλία.
Ματίας Χαμογεωργάκη.
Μετιλίνη Μαρία Μημάρου.
Μυρτών Οδάρα.
Νεφέλη Κατανάκη.
Παρασκευή Βρίζα.
Sorry. Πολυκάρπος Χατζηπερικλή.
Πολίνα Αντωνίου.
Ραφαηλία Αλεξάνδρου.
Σαμά Σάση.
Συμβουλίδης Παναγιώτης.
Walid Σοκ.
Γιάελ Χέλερ.
Γιάννης Πίστολας. Το φωνάζω.
Okay. Περιμένουμε.
Thank you for
Okay, can you...
Yeah, of course. Νιώθω σαν τηλεπαρουσιάστρια. Όχι, βγήκα με τα ανάτομα μήνυμα. Yeah. Thank you to the committee for their hard work and dedication in bringing this Congress back to life after a 4-year break.
Next, we'd like to invite the volunteers who have worked tirelessly behind the scenes to ensure that everything runs smoothly to come up on stage to receive their certificates by Myrton Odora, the head of the volunteer team.
So first, we have Julia Al-Issa.
Okay. Violeta Peta.
Πινελόπη Καβαλιεράτου.
Ασημίνα Καραμάνου.
Αντωνία Φασούλα.
Ελένη Ανιφαντή.
Ουρανία Χατζιπαρασίδη.
Χριστίνα Χρήστου.
Αναστασία Λεμπεντέβα.
Μαρία Μούκα.
Ελεονόρα Τριανταφυλάκη.
Γαβριέλα Καβαδία.
Αδαμαντία Κρατημένου.
Έριχ Στρούκερ.
Δαβίδια Ψυχογείου.
Μαρίτσα Δεσμήνη.
Σάμπα Αμπουσάμπα.
Αλαμίρα Λίν Μουκμάλτζη. Sorry.
Νταϊάν Λόπες Σοάρες. Faster.
Σταυρούλα Σάμπα Κουτσούμπα.
Μαρία Σταυροθεοδόρου.
Αλεξάνδρα Μπότσι.
Μαργκό Κουρκουλιώτης.
Μάθης Κρούγκερ.
Ρεμπέκα Ζιπ.
Okay, so that's it. I'm Rebecca Zip. Και Γαβριέλα Καβαδία. Thank you. Συνεχίζουμε. Κάτσε εκεί πάνω.
We couldn't have done it without your hard work and commitment. Thank you so much.
Finally, we'd like to thank the International Biomedical Congress volunteers who helped make their 10-year anniversary Congress a success. I would like to invite to the stage Dr. Andreas Yalouris.
Well done, everyone. So, yeah, because it's certificate time, I would like to, on behalf of the School of Medicine, to thank all of the participants and volunteers for the 10th International Biomedical Congress organized by the School of Medicine and coordinated by the Deputy Dean, Dr. Ioannis Patrikios. All the certificates from the entitled students will be awarded outside of the room in the reception area. For those who are not here, they can collect them directly from the school. All right? Once again, well done, and thank you very much.
Thank you to everyone who helped make this Congress a success. We hope to see you all again next year. Have a wonderful evening.
Guys, we have a surprise at the cafeteria, so please join us.